Good evening, everyone, and we have a great pleasure to welcome you all for this very exciting session, Liver and Biliary Oncology Summit. Without wasting a time, it's a great pleasure to welcome and invite Dr. Shyam Agarwal, sir, Chairman and Head of the Department from the Department of Oncology at the prestigious Sir Gangaram Hospital, Delhi. So, once again, ladies and gentlemen, good evening to everyone. And now I give the floor to Dr. Shyam, sir, for his welcome note. Sir, good evening to you. Over to you for your opening remarks, please.
Thank you, Tarun, and thanks to all the people who have joined early for this webinar, which is going to be focused on hepatocellular carcinoma and biliary tract cancers. This is co-sponsored by AstraZeneca and other partners. Thank you very much for letting us join together. So we have an extremely packed program, which is going to be focusing on these two types of cancers, the incidence of which over the years is actually increasing. And not only that, from a disease or both the diseases actually, which had very much poor outcome in terms of recovery, has really things have evolved so very rapidly in the last one decade or so with the availability of molecular oncology, molecular biology, immune checkpoint inhibitors, targeted this particular webinar focused on HCC and on biliary tract cancers. So, with these remarks, we will move on. As I said, we have an extremely packed program. And I'm told Dr. Naresh Bansal, who is the senior consultant in gastroenterology at Sir Gangaram Hospital, is not available. So I think the first part is focused on the epidemiology. Mr. Tarun, is that correct?
Yes, sir. Yes, sir. So the topic is, of course, liver cancer on the rise, insight into etiology, pathogenesis, and burden of SCC in Indian population. So the slides are visible to you. So we can say next, if you allow us.
Right. So, right. Correct. So I'll, cover up for Dr. Naresh Bansal briefly, just to, talk about on the etiology, pathogenesis, and the epidemiology of HCC in Indian population. So next slide, please. So can you change the slide? Okay, so these are the statistics from around the globe. Uh, 850,000 plus cases occurred, in 2022. And as you can see, the mortality is so very high to the tune of more than 750,000. And the median age of diagnosis is 66 years, and median age at death is 69 years. And there is a lifetime risk of developing this disease, 12.7 per 100,000 for men and 4.8 per 100,000 in women. And the median survival, as you can see, is 6 to 20 months. Next slide, please. So these are the etiology or the distribution of HCC in Asia, where you can see the most common source of HCC, followed by Europe, Africa, North America, and South America. There are certain differences in the frequency of hepatitis B and hepatitis C as a cause of underlying cirrhosis, which ultimately, is responsible for development of hepatocellular carcinoma in most cases of HCC. Next slide. So this is the, I think not going to the details of this slide, but if you look at the Indian this thing, it's in the green and it is less than 1 per 100,000. So in India, the incidence is not all that much as compared to Southeast Asian countries, where the incidence is more than 9 per 100,000 population. Next slide. Yeah, so I think we'll skip this. The next slide. Right. So coming to the figures in India, as you can see from Globocan data of 2022, nearly 38,000 cases diagnosed in a year, and 30, almost 37,000 deaths happening each year. And you can see the male-female ratio, 26,000 versus 10,000. The incidence of HCC in cirrhotics in our country is 1.6% per year. So underlying cirrhosis is a huge etiological factor for the development of HCC in all over the world. So possibly due to the fibrotic changes and the immune profile changes and the angiogenesis changes which are happening in the liver as a result of fibrosis and cirrhosis caused by various factors. Next slide. So I think these are the age and the male preponderance, 4:1, as we said. And this is the age structure, mostly happening, in India between 40 and 60 years. Uh, Although more than 60 years is again almost 28%. So most of these people are beyond the age of 40 years. Next slide. So this is the state-wise. If you can see Arunachal Pradesh, you can see Mizoram, so in the north side, and even in West Bengal and Sikkim. So these are the areas where the incidence in India is more common for the development of HCC. Next slide. So this is a similar pattern shown here. Uh, the next one. So HCC as a cause of mortality is the third leading cause of cancer-related death globally. And if you look at the Globocan data, the number of deaths related to liver cancer in 2022 were 39,000, as I told you earlier, and it's the eighth among all the cancers. Liver cancer mortality in India have decreased among men and increased significantly in women between 2010 and 2019. So these are some statistics to sort of remember, but by and large, the mortality is extremely high for patients with HCC. Next slide. So these are the projected numbers for men and women, and the annual rate of change of prevalence in females, as you can see, is much more than as compared to males. So in 2025, the overall incidence of HCC is expected to be crossing 40,000. So the numbers, as you see, are increasing year on year. Next slide. And this is the survival rate by the stage. I mean, if it is localized, you still not good. Only a third are having a 5-year survival. And as you go to the regional disease, distant disease, the outcome is by and large dismal. And if you look at the 44% are patients who are advanced stage disease, and local regional disease is much lower. Next slide. Okay, so this is the stage of the disease at the time of reporting, as you can see. So I'll just focus on the second last column, which talks about treatment versus curative treatment eligible. So curative treatment eligible would mean indications for RFA, for or MWA for that, microwave ablation, or surgery, that is the removal of the tumor, or liver transplantation. And if you see at that second last column, those options are available only to around 10% of the patients. So, which means that the detection of cancer for HCC is mostly in stages where cures are elusive. And therefore, you're talking about disease control and giving them better quality of life. Next slide. Okay, so this is the trends in etiology. So it is study from All India Institute of Medical Sciences, over 1,000 patients. So HPV virus is the culprit here in that HCV. Alcohol, you see the number of patients are and cryptogenic are much lower. And unknown, which I think would possibly, go into the NASH category. The numbers were like 169 out of 1,000, so 10%. Then, although they have a separate category of NASH, but then NASH and NFLD are sort of going up now with the increase in the obesity, lifestyle, diabetes, and so on. Next slide, please. So this is to share the etiology. As you can see, the non-viral etiology of alcoholic liver disease, NASH, and miscellaneous are contributing around 36%. So 18% alcohol, 17% NASH, 20% HBV, and 16% HCV in this particular study.
And Dr. Sham, sir,
So
sorry to interrupt.
these
You
are
have
the
2 minutes. Would you
four.
mind to conclude? Can sir,
Okay,
can we
just give
just
me
yeah.
change the slide. Yeah. So I think the idea. Can you have the next slide or maybe the last slide? So these are the changing patterns of the etiology for HCC as you saw them before. So now, of course, as I said, NASH and NAFLD are coming up, and with the control of hepatitis B, so that incidence is still though high, but it is on the decline. Next slide. So that's another issue. As I told you, next slide, majority of the HCCs, 10 to 15%. Next slide, please. Next slide. Yeah. So 9 to 27% of these patients may not have cirrhosis underlying. So that is another issue to remember, that if you don't have a patient with cirrhosis and there's a lesion, biopsy is sort of mandatory for non-cirrhotics to the diagnosis of HCC to be established. So can we just finish this? So this is emerging NAFLD, as I said. So this is becoming an important area of for consideration. Increasing NAFLD associated HCC has several implications because universal HPV vaccination and curative treatment of HCV may not significantly reduce the future incidence of HCC because of the NFLD on the rise. So I think with this, I'll stop here and go to the next talk. Thank you very much. Over
Thank you,
to the
sir.
organizers. Yeah.
Yes, sir. So thank you so very much for setting our context and a brilliant presentation as always. Now we move to the another interesting discussion, and this is a consensus management protocol for early detection and presentation of hepatocellular carcinoma. To do the honors, may I have a pleasure to welcome and invite Dr. Ashish Kumar sir from Sir Gangaram Hospital. So once again, good evening, Dr. Ashish sir. Thank you so very much for joining, and the stage is set for you, all yours, sir.
Hmm. Good evening. Thank you, Mr. Tarun, and thank you, Dr. Shyam Agrawal, for having me here. So, I'll share my slides. My slides are visible now?
Yes, sir, we can see
Ah,
your slides. You can start your
yeah.
session.
So, I'll be presenting the consensus management protocol for early detection as well as management of these patients. So as you all had seen from the previous presentation by Dr. Sham, that very high mortality. In fact, all them are die. So very high mortality. So, and there are lots of guidelines. We have European guidelines, Asia Pacific guidelines, British guidelines, American guidelines. So there are plethora of guidelines. But most of the guidelines are based on the data from the West. So by meaning Indian National Society of Liver, in ASL decided to have our own Indian guidelines. So we published our first guidelines in 2014, and then we have now published the latest version of those guidelines, the third version, into last year 2024. So we have our own guidelines, and most of this are formulated by the oncologists and gastroenterologists from India, and surgeons, intervention radiologists, all are from India. So how I'll go stage wise. How do we diagnose HCC early? So as you all know that HCC, if diagnosed early, it can be cured. So the staging of HCC is done by Barcelona Clinic Liver Staging, where it is divided into 5 groups, 5 stages. So if when the patient presents in early stage, that means stage 0 and stage A, then he can receive curative treatment. But once he presents slightly later, stage B, C, or D, then mostly he can be treated only with palliative treatment. So WHO criteria for cancer surveillance says that the cancer should be common, high with high mortality, and it should have a high risk predisposing population. And any test which is used for cancer surveillance should be acceptable, and there should be effective treatment. So if these criteria are met, then these patients should undergo surveillance for cancer. So HCC meets all these criteria because HCC is a very common cancer, sixth most common cancer. HCC has got high mortality. It it has a high risk predisposed population, that is cirrhotics. It has a very acceptable test for screening and has an effective treatment in early stages. So, cirrhosis is the predisposing condition for HCC. That is the first fact. And early detection of HCC has better chances of cure and survival. So, there is a definite role of surveillance. And with surveillance, we are likely to find HCC in early stages. So, in our second version of INASL guidelines, we actually mentioned that patients who have cirrhosis of any etiology, early cirrhotics like child A and B cirrhotics, surveillance every 6 months, and even in child or curative treatment or some form of treatment, they should all. And the surveillance should be based on 6 monthly ultrasound and a tumor marker, that is alpha fetoprotein level, that should be done every 6 months. So once cirrhosis is diagnosed in any patient, then every 6 months he should undergo surveillance. And if when any small HCC is diagnosed at any part, and since it is diagnosed during surveillance, so it will be small and he should be treated and HCC would be cured. And then we should continue surveillance in every 6 months for these patients as well. So, does surveillance improve survival? That is a question. So, many studies have been done, and this is a meta analysis which was published a couple of years ago. It included about 39 articles with 15,000 HCC patients, and it showed that surveillance detects early tumor, and patients with diagnosed HCC through surveillance are more likely to undergo curative treatment, and surveillance does improve survival. So, surveillance is a must. And for every cirrhotic patients, we should ensure that they should undergo 6 monthly surveillance. Now, what is new in staging? I told you the usual staging is through Barcelona Clinic liver staging, BCLC staging. This is the traditional staging. This was published, they had many versions of BCLC staging. This was the last version which they had published in 2022. So they divide liver cancer into five stages: 0, A, B, C, and D. The INASIL, which were guidelines which was published last year, have further subdivided this staging into A1, A2, B1, B2, B3, C1, C2, and D1, D2. This is based on the fact that these stages, like early stage, intermediate stage, advanced stage, these are heterogeneous group. There could be many dimensions to it. So if we further subdivide, then we can offer nuanced treatment to each of these subgroups. So in India, we generally follow this staging system, which is a further refinement of the BCLG staging system. So these are the groups. So BCLC stage C, because BCLC stage C, the traditional staging is that it's a uniform group, but we said that it is can be further subdivided into C1 and C2. C1 are those patients who have portal vein tumor invasion but without any extrahepatic spread, and so these patients can be offered some form of loco-regional therapy. For example, they can be offered SBRT, or they can be given tear, and so on and so forth. While the C1 group, C2, the group which have got extrahepatic spread, they can be offered systemic treatment. So another thing which we mentioned in our guidelines is that all HCC patients must be discussed in multidisciplinary tumor board. So when HCC presents to us gastroenterologist, or to when present to our oncologist like Dr. Shyam Agrawal, or when it presents to any surgeon or intervention radiologist, it should be discussed among all the stakeholders, all gastroenterologists, hepatologists, intervention radiologists, radiotherapists, so that best treatment is decided by the discussion. Because then, with discussion, the treatment can further be tailored according to the stage, according to the presentation, according to the patient's etiology, according to patient stage, and all these nuanced decisions can be taken. Now I'll come to stage-wise management for individual stages. So what do we do if we have a small, less than 2 centimeters single tumor in a cirrhotic patients? So for example, this is a CT scan and we have a tumor which is less than 2 centimeter. So if the performance status CTP would be ablation. Alternative treatment, if there is no clinically significant portal hypertension, would be resection. And if liver transplantation is available, we should counsel this patient for liver transplantation. But if the same tumor, small single 2 centimeter size tumor, is present in a patient who has slightly advanced liver function like CTP B or C, or if he has advanced performance status like 1 or 2, then the best treatment would be liver transplantation rather than ablation or resection. If liver transplantation is not available and the CTP function is B, then ablation can be offered. What if the tumor is slightly larger, maybe 2 to 5 centimeters size? So this is a slightly larger tumor. You've often seen this kind of CT scan. Again, if the CTP score is good, CTPA, and performance status is good, and tumor is between 2 to 5 centimeter, the best treatment would be liver transplantation. With change of the liver, the soil, fertile soil of HCC would also change, and it will give a new life to the patient. Alternative treatment, if liver transplant is not available, is resection, but only if clinically significant portal hypertension is not there. If liver transplantation is not available or not feasible, then these patients can be offered a kind of ablation that is called a microwave ablation, or even if the tumor is of a slightly larger size, then microwave ablation plus TACE can be offered for these patients. What if the same kind of tumor, that is 2 to 5 centimeter single tumor, presents to a patient who has slightly advanced liver disease like CTPB or C? Then the best treatment would be liver transplantation again. And if liver transplantation is not available, then microwave ablation and TACE can be offered. These patients would not be offered resection because of advanced liver disease. What if there are 2 to 3 tumors and but all of them are within the Milan criteria? Milan criteria is the standard liver transplantation criteria which is followed worldwide. So, for example, there's 2 tumors. One is about 3 centimeter, the another is 1 centimeter, which is within the Milan criteria. So, if child function A, good performance status, best treatment, liver transplantation. If liver transplantation is not available, then we can offer microwave ablation, TACE to individual tumors, and we need to add systemic therapy here because these are multiple tumors are there, and to prevent any recurrence, it is better to add systemic therapy after the loco-regional therapy. If the patient has advanced liver disease or advanced performance status, then liver transplantation is the best treatment. If liver transplantation not available, then microwave plus TACE plus systemic therapy. What if the tumors are beyond Milan criteria? So this is a CT scan of a patient who has multiple tumors. So one tumor is here, one, two, three tumors are in the right side. So these are tumors are beyond Milan criteria. So if the tumors are beyond Milan criteria, good performance status, good child function, but if they fit into the UCSF criteria, it is slightly advanced liver transplant criteria where the size is 6.5 centimeter, then we can offer upfront liver transplantation if it is available. But if the tumor is even beyond UCSF criteria, we should first downstage these tumors, and only then, if there is successful downstaging, only then offer liver transplantation. If liver transplantation is not can offer taste or tear, and we need to add CRT also in some of these tumors, and which can be followed by systemic therapy. What if the same tumor beyond Milan criteria and advanced liver function test, for example, child function C, then even liver transplantation cannot be done. So first we need to offer best supportive care, and with best supportive care, if the liver function improves to CTP less than 8, then we can think of either downstaging these patients or upfront liver transplantation if the tumor is within UCSF criteria. So for downstaging, we can offer TACE or TARE, and then we need to add systemic therapy, but only if child function is less than 8 CTP score. What if the tumor infiltrates the portal vein? So this, we can see the portal vein here, and we can see that a tumor is infiltrating the portal vein. So these patients belong to BCLC, inacil BCLC staging C1. So the best treatment would be loco-regional treatment in form of TARE or SBRT to portal vein tumor thrombosis, or we can even add TACE to these patients if there's portal vein tumor thrombosis staging is VP 1, 2, 3, and we need to add systemic therapy. Alternative treatment is we can give systemic therapy alone. We may not add loco-regional therapy depending on case-to-case basis. But if advanced liver disease, then best supportive care is the treatment. But if he improves, his child function improves, then TARE or SBRT or SBRT plus TACE and systemic therapy, all these can be offered if CTP function improves to less than 8. What if there's extrahepatic metastasis? So this is a PET scan where we can see some metastasis to brain or some metastasis to the bones or even lung metastasis is there. So depending on case to case basis, the best treatment would be systemic therapy. But if there are only one or two oligometastasis, then we can do, there's an emerging role of loco-regional therapy to those oligometastasis plus systemic therapy. But if there's advanced liver disease, then best supportive care. If liver function improves, then systemic therapy can be given. What if the patient presents with HCC and has decompensated cirrhosis, that is CTPC? So we see here with a very small shrunken liver, we see a liver tumor, HCC, and we see decompensated cirrhotic patient, ascites is there. So the best treatment, if the patient falls within UCSF criteria with decompensated cirrhosis, the best treatment would be liver transplantation. And if the patient's tumor is beyond UCSF criteria, performance status is bad, then best supportive care. So this is, I already mentioned, this is the INASL BCLC staging system where we have a nuanced treatment guidelines for all these intermediate advanced stages, depending on their substage and depending on their loco-regional treatment options and systemic therapy. So when do we use systemic therapy to these patients? Can we combine systemic therapy with local regional therapy such as TACE? So according to Dr. Kudo, who's a world-renowned figure on HCC therapy, he says that systemic therapy can be used in all stages of cancers. So there's emerging role in even in early stage, that is BCLC A. So there have been studies like IM Brave 050 and other stages where even after curative treatment, you can offer systemic therapy, but that is only in the research setting. For intermediate stage and advanced stages, there is definite role of systemic therapy in combination with loco-regional therapy. So TACE alone versus TACE plus systemic therapy, there's a trial called LEAP trial, which showed that patient who received systemic therapy along with TACE had better overall survival and better progression-free survival. Similarly, there's an EMERALD trial where TACE alone versus TACE plus systemic therapy, again, better progression-free survival, especially when bevacizumab was given into these patients. Then there's a launch trial where lenvatinib alone versus compared with lenvatinib plus TACE, and again it showed that combination therapy achieved better progression-free survival. So, what are the practical tips on combining therapy? So, for intermediate stage of we prefer combining TACE with systemic therapy because of better progression-free survival, and because of the among the systemic therapy options we have durvalumab plus bevacizumab, and we also can use lenvatinib plus pembrolizumab for these patients. And for advanced HCC patients on lenvatinib monotherapy, we can consider adding on-demand TACE whenever is feasible, because launch trial had shown that it's
Sorry to interrupt, sir.
yeah.
Request you to conclude your presentation
Yeah,
in
yeah.
1 minute.
I'll finish
Thank you.
within 1 minute. So bottom line is that don't use TACE alone if you can add systemic therapy, and don't use systemic therapy alone like lenvatinib if you can safely add TACE. So combining modalities would lead to better tumor control, delayed progression, improved survival. And even in early stages, there are multiple trials are going on, which will soon see data that even in early stages, there could be imaging data to show that they can be, these systemic therapy options can be used. So, which systemic therapy options are available in India? So, we have multiple options like atezolizumab, lenvatinib, sorafenib, durva, and durva alone. All these are there. We'll hear more in the subsequent presentations. So, I'm not going into details, but if to choose Tizobev and Tremidurva if they and Tremidurva cost is there. So the adverse effects are mentioned here, which are there, and how to can skip. And there has emerging role of SBRT. We need to discuss these patients and if see if SBRT can be given in these patients, especially if there is portal vein tumor thrombosis. So take home message, all patients must be staged according to the INASL BCLC staging system. There is a strong role for combining therapy, especially in intermediate and advanced HCC. Whenever systemic therapy is indicated, prefer to give immunotherapy due to higher efficacy. SBRT is an excellent modality with promising result in all stages, and we must familiarize ourselves with indications, contraindications, and prescribing information and adverse effects of various treatment options, including immunotherapy. And all HCC patients must be discussed in multidisciplinary tumor board before assigning any treatment. Thank you for your patient hearing.
Thank you, sir. Thank you for the excellent presentation. So as we move forward, I would like to invite for the next session, Dr. Vivek Agarwala for the talk on management of intermediate stage HCC. What's the recent advances? Over to you, sir.
Yeah, I hope I'm well heard and my screen and the slides are well visible.
Yes, sir.
Thank you, Dr. Sham, for giving me this opportunity. I have around 20 minutes now to talk about the management of intermediate risk HCC, focusing on the changing landscape and the recent advances. A lot of things have been alluded to by Dr. Kumar already in his previous presentation, but let me see how much I would want to consolidate on what he said. So we all know HCC represents a problem statement, because if you look at the global incidence of HCC, it ranks around 7th or 8th. But when look at the cancer-related mortality, then HCC ranks third amongst all other causes. So more patients are dying than number of the patients that have been diagnosed. So it's a problem statement, it's an unmet need. And look at India, it is the 10th most common cancer type, but it is the second most common cancer-related cause for death in men. So you see that the higher number of people dying, because we mostly see men being diagnosed with HCC. And when you look at the stage of HCC, the proportion of patients that present to us, 50% of the patients are actually BCLC A and B. This is the AIMS data. And if you look at my OPD experience, most of my patients that I see of HCC are actually the intermediate stage BCLC B patients. So these are our patients whom we need to focus more in order to improve our outcomes. This is the classical BCLC algorithm. This was classically brought out in 1999. It integrated the tumor characteristics, that is the number of nodes, the size of the nodes, extrahepatic disease, vascular invasion, along with the liver function, that is by Child-Pugh score, as well as the general condition of the patient, that is the ECOG-PS. And integrating all these three, it devised a very beautiful classification of HCC: BCLC 0, very early stage; A, early stage; B, intermediate; C, advanced stage; and D, terminal stage. And this not only represented a classification and staging, but was equally prognostic and provided a very good framework for clinical decision making and treatment. Classically, when you talk about intermediate stage HCC, which is our topic today, conventionally, TACE is the treatment that has to be given, and it gave a prognosis overall survival of around 2.5 years. But there has been a lot of criticism of the BCLC when you looked at intermediate stage, because intermediate stage, as we discussed, is the most heterogeneous stage of HCC, and you have different types of patients, and using a one size fits approach, that is treating all with conventionally with TACE, is not going to improve the outcomes. And that is the reason why, after decades of research, multiple papers, 2022, the BCLC updated by classifying the intermediate stage into three categories: A, B, and C. A is the one where these patients actually fit into the extended liver transplant criteria by their size AFP, and where these selected patients could be taken for liver transplant. Yes, they could be given TACE just as a bridge to transplant, or systemic therapy as a bridge to transplant, or can be downstaged to fit them to transplant or resection. Second was the B, which was the classical category, which where TACE was applied, where well-defined nodules were there, patient had preserved liver function, patient had preserved PS, and have preserved portal flow. And third was actually the TACE unsuitable patients, where there was bilobar extensive disease or diffuse HCC. And these patients are actually the ones which were actually behaving more like BCLC-C, whereby they were to be given systemic treatment first rather than TACE, because the TACE is likely to fail or they're unfeasible. So this is the advanced, extended liver resectability criteria, where you have beyond the Milan criteria 3 nodules less than 3 centimeter to include extended criteria, which is BR1, or more extended criteria, the 5 nodules up to 5, and now even the up to 7 criteria by which you can use the patients for liver transplantation and resections. Now, coming to TACE, TACE has been the recommended standard of care for intermediate HCC from all. What is TACE? So, very simply, you insert chemotherapy along with the lipoidal agent as an emulsion into the selective hepatic artery which supplies your nodule, thereby creating an ischemic injury as well as selectively giving them cytotoxic chemotherapy. Most commonly drug used is the doxorubicin. And TACE has clearly shown, as opposed to best supportive care, more survival for our intermediate stage. Different types of TACE are there beyond the convention. Now you have DEB TACE, whereby some beads of doxorubicin is used. And what DEB TACE as compared to the TACE has shown that it is as a lesser side effects, like lesser post embolization syndrome, and slightly there may be sometimes you have to select your cases as per the feasibility to see what is the response. In larger size tumor there may be better response, in smaller size tumors there may be lesser response. Other modifications are there, like hepatic artery infusional chemotherapy, very difficult to do because requires multiple procedures. Each time you give chemotherapy you have to put a catheter in the hepatic artery. Not very easy to do, but sometimes has shown better response for larger nodules. And balloon TACE is also another thing that has been shown in some of the newer kinds of TACE to have give some advantage. So DEB TACE, just as I said, that can achieve higher dose of doxorubicin and sometimes has a better response in larger tumors and less post-embolization syndrome, less hospitalization. But just as I said, that when you have huge disease and multiple nodules, bilobar disease, diffuse infiltrating nodules, what you see in the pink and the yellow, these are the tumors in the intermediate stage who have a poor response to conventional TACE, who are basically TACE unsuitable, and there you need more techniques like systemic therapy to come in. So when you talk about TACE, it has critical limitations. What is it? That once you do a TACE 2 or 3 times, it leads to refractoriness and irreversible liver damage, and thereby you cannot give TACE more because it doesn't work. Secondly, when you do 2-3 times TACE, because of the recurrent ischemic injury to the non-tumorous liver, there is cumulative decline in hepatic reserve. So if you continue to giving on TACE, when they will fail, these patients are no longer fit to receive systemic therapy. So giving TACE more and more is probably not the way to go. And third and most important is that when you do TACE and when you induce ischemia to the tumor, what you see is that because of the ischemia and hypoxia, there are multiple pro-angiogenic factors that are released, notably vascular endothelial growth factor. And this vascular endothelial growth factor leads to classically tumor progression at the margin of the TACE that is done. And there is new tumor coming in. Now, this represents a beautiful therapeutic window because now we have anti-VEGF agents which can be used for these tumors, and therefore it represents quite a rationale why TACE can be combined with anti-VEGF drugs in order to prevent these kind of hypoxia-induced angiogenesis and use this for better newer strategies. Now, TARE classically is used as an other loco-regional approach for patients where TACE cannot be done, or an alternative approach. What you classically do is use yttrium 90 microspheres. So therefore it's also known as selective arterial radiotherapy, and you give beta radiation. And what is the difference between TARE and TACE is that the primary mechanism here is actually a brachytherapy and internal radiation to the tumor rather than the ischemia and cytotoxicity. Generally speaking, multiple meta-analysis has shown that the overall survival of TARE and TACE is generally equivalent, but there are studies that have shown that TARE is slightly lesser hepatotoxic and may have better time to progression. It has a better longevity of the response that is seen with TARE. Side effect profile, post embolization syndrome with TACE and with TARE, sometimes there can be radiation induced liver disease, which is something like a sinusoidal obstruction syndrome that we see in our transplant patient, and this can be very risky. So therefore, the dose to the liver is restricted to 40 gray and not exceeding to the 40 gray in the normal liver. In portal vein thrombosis, we all know that hepatic artery is the only dependent source for the liver, and if we give TACE, then it will cause a ischemic injury. So TACE is contraindicated whenever there is major portal vein thrombosis is there. But here the TARE is the preferred modality, and in this category it has shown that TARE has improved overall survival over best supportive care. Also, what TARE can do is that it can do something known as a radiation lobectomy or a radiation segmentectomy by inducing a functional residual liver hypertrophy where it is not done, and atrophy of the liver where it is given. And because of this, the cases where there is marginal liver function, cases where you plan to do resection, cases where plan to do transplant, TARE is something where you need to very cautious in selecting your patients. Now we have beautiful studies of TARE coming in as a neoadjuvant strategy, as a treatment strategy in your intermediate stage patients. So what used to be before conventional TACE is now replaced by an ablative TACE. You have higher dosage of beta particles, more particles being given, and larger dose is being delivered to the liver tumor by a different dose calculation method, and decreasing the shunt to the lung, decreasing the dose to your normal liver, and increasing the dose up to 410 gray as in the legacy study. And the newer doorway study has shown that even up to 510 gray can be given to the liver. And what are the response rates? 80, there was a very high response rate, and 86% 3-year survival, and 92% for the patients where it was used in a neoadjuvant strategy. So almost 27-28% patient, this was used as a neoadjuvant strategy, and it led to a very good response rate, and 28% patients were able to go ahead with transplant or resection. And if you look at the recent doorway study, the complete response rate in the doorway study was 93% and 98% overall responses was there. So even transplant is not required, and you can observe these patients when you give TARE. So TARE, with the recent recent studies have shown remarkable results, and it can be used as a very good alternative to TACE in their intermediate stage HCC patients. This is the study that showed that ablative TAVE has better response than the conventional TARE. And this is the study which shows that personalized dosimetry has better responses, better survival as compared to the standard dosimetry. And this is the Japanese study that I talked about, which showed that as compared to DEB TACE, there is higher time to treatment progression with a significant hazard of 0.36 with TARE as compared to TACE. Now, there has been a paradigm shift also in the rise of systemic therapies when you talk about intermediate stage HCC. Now, this was the REFLECT study, lenvatinib versus sorafenib non-inferiority trial, and it also included patients of intermediate stage HCC which were not suitable for TACE. And in this population, the objective response rate was 40% in the overall REFLECT trial, but in the intermediate stage, what we saw that REFLECT study showed a 61% overall response rate. So better responses in the intermediate stage HCC. IM Brave 150, Atizo plus Bave, better PFS and OS in the entire BCLC-C. But if you look at the exploratory analysis of this study where the BCLC-B patients, the intermediate stage, were included, you see that here the hazard, which was 0.7 in your BCLC-C and the entire cohort, the hazard came down to 0.6 for OS and PFS. So better results in your intermediate stage patients with Atizo-Bev. And if you look at the response rates in the entire cohort, the response rates were 35 to 40%. But if you look at the intermediate stage cohort, the response rates even exceeded more than 50% with higher number of CRs with Atizo-Bev. So in intermediate stage, these systemic treatments are working equally good. Durva-Tremi in your advanced stage HCC, now also a standard of care, especially for patients who are contraindications for BEV and having high risk of varicose bleeding. And then you look at the subgroup of BCLC-B, you see that the equally good results are there for durvalumab as well as for the combination durvalumab-tremelimumab. So these are all. And now there is again the stage and the era of combining local treatment with systemic treatment. Then what are those patients where you need to combine this local treatment and systemic treatment? So classically, these are those patients which are not suitable for TACE alone and where the TACE is likely to fail, where you have multiple nodules up to 7 in both the ear, or diffuse infiltrative TACE, or patients who could actually be rescued to transplant, where you give aggressive treatment to have better response and move them to transplant, and you don't want to do TACE more and more. So multiple studies that looked at combining the local treatment with TACE and systemic therapy. And the first study that actually succeeded was the tactics, TACE versus TACE plus sorafenib, and there was a clear survival benefit in PFS shown in this study and some numerical benefit in the OS. Launch, again, it was not lenvatinib plus TACE versus TACE. So actually lenvatinib versus lenvatinib plus TACE, but still showed lenvatinib plus TACE has a better overall survival as compared to lenvatinib alone. And there were also studies of combining sorafenib with SBRT, combining sorafenib with TACE, all showed improvement. And there were other studies of TARE also combining with modern immunotherapeutic agents like nivolumab, pembrolizumab, and durvalumab, all showing feasibility and improvement, slightly improvement in the overall survival in those patients where TACE was unsuitable and these patients didn't used to do good. So this was the
I
tactic.
request you to conclude your presentation in 1 minute.
Yeah. So this was the tactics, clearly showed a survival benefit in the PFS. OS was similar, and tactics L looked at the lenvatinib. It was single arm study, lenvatinib plus TACE, showed similar PFS as compared to the tactics of the sorafenib OS and showed a feasibility. And again, the combination of immunotherapy plus TACE plus VEGF, and it is very much feasible and supported by biological rationale. LEAP study showed that pembrolizumab plus lenvatinib plus TACE has better PFS as compared to TACE alone. OS was not improved in this study, but there was a clear improvement of PFS as well as the response rate. Emerald study, durvalumab plus bevacizumab or durvalumab. Here also you can clearly see an improvement in the PFS and response rates and time to treatment progression as compared to TACE alone. And this is the latest one, is the talent TACE, where atezolizumab was combined with TACE, and in the TACE arm, you can clearly see there was an improvement in the PFS from about 4 months with the hazard of 0.71. Now, one of the criticisms is that none of these studies showed improvement in OS because of the heterogeneity of the patients, but still it represents a remarkable improvement because there is definite improvement in the response rate and PFS. And response rate and PFS is something that can be employed in your borderline resectable patients, and you can move them to transplant, and you can rescue your unresectable advanced SCC patients and move them to transplant. Now, if you look at the inclusion criteria, all were different. And if you look at the toxicity, now this is also important, that LEAP was found to be the least toxic, or all the three. There were higher toxicities as compared to the placebo arm, and therefore you need to be very cautious regarding selecting your patients. Now, this is the modern concept of ABC, that is using systemic therapy and not the TACE to convert your patients of intermediate stage SCC to curative treatment, whereby you do a curative resection or RFA or transplant, and you don't need to give them further treatment. And this was explored in one of the Japanese study, whereby giving atezo plus BAVE upfront to these unresectable HCC patients, 35% of the patients achieved complete response, and around 23% of these patients were actually found to be cured. And now there is a sandwich treatment that is explored, is that you give atezo-bev to these patients. Then if they are responding well, you take them for lenvatinib plus TACE, and after that you again start atezo-bev as a maintenance, and then when these patients are cancer free, drug free, you stop the treatment altogether. So this is what is the modern treatment, whereby patients were unsuitable for TACE, you take for this ABC conversion treatment, and almost 30% of these patients you can convert them to cancer free and drug free. So lastly, talking about systemic therapy. So now we all know we have multiple options of systemic therapy, starting from lenvatinib, atezo-bev, to IO options like nivo-ip, durva-tremi, as well as the single agent IO options. And how to choose in all these options is something that is what we are all confused about. So this is one of the very nice reviews by Dr. Kudo, where he has included all the patients of all these IO plus VEGF, as well as IO plus TKI, as well as IO plus IO trials, as well as their control arms. And what he has clearly shown is that when you look at the IO plus VEGF and IO plus TKI trials, as well as the IO plus IO, there is a marked fall in the OS early on in the IO plus IO studies. But what you see is that later on, those who respond to IO, they have a good response, and they are achieving a plateau, just like IO plus VEGF also. So what we can conclude from this is that IO plus VEGF regimen, they exhibit a very sustained anti-tumor effect with a continued OS benefit right from the start. But IO plus IO treatment is something like a all or none response phenomena. The responders, they demonstrate a quick and deep and durable response, but those who don't respond and have a quick progression or have a very grade 3 or grade 4 immune related adverse event. Also, what is there is shown is that there is a clear response relationship between the tumor depth of response and the OS. So higher is the depth of response, more is the OS, and this depth of response is something that you can achieve mostly with IO regimens in your aggressive tumors, but sometimes also with the IO VEGF regimens. And what is important is that when you are selecting your patients for IO, the tolerability assessment and a biomarker based early response assessment and moving on is very critical. So, what is staged that when you are seeing a patient of unresectable HCC, you should see that whether these patients are able to tolerate grade 3, grade 4 IRAE or not, and whether you would be able to rescue them or not, and whether they are having good liver function, whether they are young or not, whether they have extensive extrahepatic spread, high tumor burden, and they do not have a portal vein, major portal vein thrombosis. So these are there, and these patients are the ones where you should go for IO. And whereas those patients which are anti-VEGF fit and do not have a very high tumor burden, are slightly elderly, unable to tolerate grade 3, grade 4 IRA, should be chosen for IO-VEGF. And when you are giving IO, Durvatremi or Nivo-EP may be 2 cycles, Durvatremi may be single cycle. You should go for a biomarker response assessment early on at 3 to 6 weeks. And if you do not see a response in the AFP, PIVCA or the AFP-L3, these patients are unlikely to respond to further IO. So it is critical to change early to IO plus VEGF or lenvatinib, because if you continue to give IO, then you are going to lose these patients early on. So this biomarker-based response assessment early on in this IO is something very critical to these patients, and you should see. And lastly, we cannot undermine the role of a multidisciplinary team whenever we are treating any patient of intermediate stage HCC, because everyone in the team has a role to play and in the clinical decision making of how to treat that patient, whether to go for systemic therapy, whether to go for TACE, whether to go for TARE, whether to go for surgery, and it's a team effort that is required. So with this, I conclude that intermediate stage HCC, it's a biologically diverse disease. It represents an unmet need, and no longer a conventional TACE is the correct treatment for all intermediate stage HCC. We need to see which category it belongs to and address the tumor burden as well as the microenvironmental complexity to select the correct treatment. The rationale to combine TACE with immune checkpoint inhibitors as well as the anti-VEGF directed treatment is the new advancement that has come here. It brings in the synergy to improve the outcomes. There are multiple trials that have shown that there is improved PFS and response rates by combining local directed treatment with systemic therapy. And there are other trials further coming on which will help us to decide more of these treatments. And in the systemic therapy options, now also we have wonderful and multiple treatment options. We need to select our patients very carefully. We lack biomarkers in order to select our patients. Which is the need of the moment. And multidisciplinary team approach is something that is the key for optimizing treatment outcomes and improving the quality of life for our patients of intermediate stage HCC. With this, I thank you all for patient listening. And if there are any questions, I'd be happy to answer them. Thank you.
Thank you, sir. Thank you for the excellent talk. And as we move forward, the questions can be taken in the chat box. And as we move forward, I would like to invite Dr. Akhil Kapoor, sir, to moderate the panel. And sir is from Tata Hospital, Varanasi, and he's going to discuss the panel discussion on the immuno-oncology frontier IO plus IO, redefining HCC management in new era. Over to you, sir. And I request all the panelists to switch on the videos. So kindly invite your panelists.
Thank you. Thank you to the organizing team, Sham sir, and the entire organizing team. I request the panelists, Atul Sharma sir, Dr. Varun Goyal, Dr. Ajit Yadav, Dr. Shikha ma'am, Dr. Dheer, and Dr. Namita ma'am to be there. And if feasible, to switch on the video if feasible. Yes.
Dr. Ajit Kumar sir has not joined.
Okay.
He's stuck in OT.
Okay. ठीक है. So apart from Dr. Ajit, all are there, correct? Yeah.
Yes, sir.
Yeah. ठीक. Thank you. So let's move towards this discussion. I think we were discussing about various aspects of HCC. The previous talks have also covered the same, and let's see how we proceed forward in the management of HCC with the advent of IO plus IO data, and also IO plus TKI data is also there, and now IO plus VEGF data is also there from a long time. So let's see how we move forward. So let's come to some basic part, then we'll move towards a specialized part related to immunotherapy. So I will request first Dr. Namita ma'am to comment how common is HCC in your OPD, and what is the usual stage at which the patient present to you?
Yeah. So I'm audible?
Yes, yes, ma'am.
Yeah. So I think most of the patients of HCC coming to medical oncology OPDs are intermediate or advanced stage. The early ones are going to the surgery and the liver transplant OPDs. So in my OPD, I think it's mostly B or C, BCLC, B or C.
BLC, B or C. I think
Yeah.
that is the situation throughout the country, and a lot of patients present with B and C. And this is the harsh reality which we need to accept, that most of our patients are at advanced stage, and we are trying to do something. We are trying to find ways and means, something like screening, which is in very nascent stage in various parts of the world. We have not yet started in our country, but I think something is needed to to diagnose the disease at a younger stage, at a more nascent stage, to make it useful. So this is the liver cancer worldwide data, and yes, it is a significant percentage. We cannot ignore it. In every OPD, for example, if in that TMH4C we have OPD of close to 700 to 800 patients per day minimum. Out of this, at least 20 to 30 patients are having HCC in daily OPD. So it is not a very small number. It was initially thought of as small numbers, but now we see it very frequently, and the incidence has actually increased, and patients are reaching to oncology centers now. That is the important part. That is why we are able to have more diagnosis at least. This is the Globocan data as well. It is presently 11th most common cancer type and 8th most cancer-related death in our country. And very important that the cancer history data also shows the similar problem. And male to female ratios around 4:1. So Dr. Varun, I request you to comment, how do you see BCLC B and C, and do you take apart from CTP score, any other score, MELD score or LV score in your routine practice? Do you document it in your routine notes, or it is done only in selected cases? What is Dr. Varun?
So, good evening, everyone. So, first of all, as Dr. Namita already told, that most of the patients present in childhood BCLC, B and C, and at the time of presentation, most common childhood wise is childhood B. A is a very less number in patient.
Yeah.
So, beside childhood scoring, we do LB scoring also, but main treatment plan and management plan is on the basis of childhood only, and we document childhood only. LB score we have started to check, but not and change any plan right now according to that.
Okay. Yeah, so it seems LB, most of the treatment guidelines are as per the BCLC and CTP score. So I think that is the routine practice. Though we know now the LB score is very important and strong prognostic effect. So Dr. Dheer, what is your comment on that? What do you think? You need to unmute yourself. Yeah.
Am I audible?
Yes, please.
Well, I agree with you and the other panelists. Basically, what we are seeing is more the problem in with the patients who are child C. In fact, the treatment options with child B are still more.
So, do you document LV score in your routine practice, or it is done in selected cases only? What is...
No, we don't document in our routine practice.
Yeah, I think this is situation similar throughout the country, except in very areas, the centers which are having specialized HCC clinics separately, only they will document it. Or if there is a procedure planned, then LB score will be documented, not a very routine practice. But yes, we will come to see the data. LB score is a very strong prognostic factor. So it is, we need to adopt it gradually and document it so that we can find the prognosis in a much better way, because CTP and BCLC have been there and we are all very utilized to it, but not very commonly we document LB. Now, again, this is from time and immemorial, we discuss about this topic. What is the underlying etiology of HCC? I think Atul Sharma sir has the maximum experience among us, and I will request sir to give his guidance and how he sees this path for further effect. Sir, Atul Sharma sir. If Atul Sharma sir is,
Hello.
yes, yes, sir. Good evening, sir.
Am I audible?
Yes, Dr. Atul, good evening. Good evening.
I think it is viral, and we are shifting towards NFLD, NASH NFLD.
Yeah, so it is viral and NFLD in your practice, correct? So out of viral and NFLD, which one seems to be more common? What do you think?
The people, those who come from far off areas, I think viral is more common in them. But those who are mainly predominantly staying in cities, I think NFLD is more common now.
Yeah, so I completely agree. So the viral component was usually previously the most common one in our country, but more and more adaptation of vaccination, and gradually NFLD is rising in city areas, at least tier 1 and tier 2 cities. NFLD seems to be significantly rising. Anyone would like to make any comment on that?
Just to add here, because
Okay.
NFLD is increasing incidence-wise as etiology of SCC. That's why it is still more difficult for screening part. Because for viral, we know that for HBV positive chronic patient, if they're chronic hepatitis, then after 40, he or she should do one yearly ultrasound and AFP monitoring and all. But regarding NFLD, like there is a whole lot of metabolic syndrome patient and obesity, diabetes. So screening for those patients in view of SCC screening, it is not no guideline for that at present, and it is very difficult to have.
Yeah, completely agree with you. There is no screening guideline, and it is very in early phase, and it is being thought of now, but it is in very, very early phase. In fact, this is article which large multicentric study for HCC in India. It showed actually NFLD is actually risen as compared to hepatitis. So this might be due to definitely some data which is being collected mainly from cities where NFLD is much more common. Hepatitis related HCC might not be reaching to cities where treatment is being offered and being undiagnosed deaths. So that is another one of the very common reason. Dr. Namita, what do you think, ma'am, in terms of your experience, and which of these patients are more difficult to treat in terms of their presenting symptoms and presenting a disease burden? As per
So I
etiology.
agree with the etiology which Dr. Atul has said. Definitely hepatitis and now NAFLD. Alcohol is of course there, all of us know. So I think with hepatitis, because we have an associated antiviral treatment which we can offer, and definitely if patients are on both the treatment for hepatitis and the liver cancer, they respond much better. We don't have that kind of thing for NAFLD.
Yeah.
And I think immunotherapy with IUs also we have a problem with NFLD etiology HCC. So definitely this one is more difficult to treat.
Correct. So I completely agree. So this is a part where for hepatitis, if we start treatment for hepatitis B and C, mostly B related, the patient itself has some improvement in the symptoms. Patient becomes significantly improved in terms of the liver reports, and it becomes slightly better, easier to manage the patient. While NFLD, it is at a stage where it is very difficult to may improve the liver profile of the patient because of the nearly permanent damage which has already been done. Dr. Dhiri, you would like to comment on that?
Sure. I'm audible.
Yeah.
I think in my practice in last 1 year, the incidence, what we are seeing, the HCC has increased more in patients who have ALD and NAFLD rather than Hep B and Hep C.
Yeah, yeah,
So I would totally agree with what Dr. Varun said, and that, in patients living in tier two, tier one cities, which we are seeing because of longevity and what we now call as MASLD, the incidence and prevalence being high of MASLD, we are seeing more and more HCCs, and more so unresectable HCCs in these patients coming because they've been asymptomatic. So, and the incidence of viral related HCC, I think, is going substantially down over the time, probably because of vaccination in big cities, tier one, tier two.
yeah. And even Korea, Thailand, in these countries where the vaccination program was launched very extensively, they have reported at least 70% decline in HCC incidence. I think something like that is gradually happening in our country as well, where Hep B, Hep C related incidence is declining very rapidly, especially Hep B, definitely, as it is vaccine preventable disease. While for Hep C, I think though patients having chronic disease like requiring transfusions, repeated IV punctures like CKD, there the incidence of the patients are surviving longer, and there the incidence of CKD and other hepatitis induced HCC is slightly on the rise, but that constitutes a very small proportion. It is mainly obesity, which is and diabetes related, or even we'll call it metabolic syndrome related factors, which are very significantly rising in our country. And as it is being propagated, India will be becoming India is already the diabetes capital of the world. So in terms of metabolic syndrome, we are actually having a very difficult scenario in the country, and we need to work upon it. First, we should work upon ourselves. Then we need to teach our colleagues, residents, and patients, and that order. So now coming to the treatment part. So this was all about the etiology, the parts which we are discussing very commonly. Now, how to treat that? Yes, we discussed about multidisciplinary approach, but the problem is that a lot of times the patient is not fit for any local therapy, and patient is fit only for systemic therapy. And also we have to choose whether to give systemic therapy or consider supportive care alone as an option. So that is a very fine gray zone where sometimes we don't have any clear answer, and depending on the situation, because BCLCC is an area where the data is very less in terms of all the treatments, but still if the patient is younger and somewhat fitter, we try to include some form of treatment and see if the patient is responding to it or not. Dr. Atul, what do you think in BCLC-C, which is a difficult zone, what has been your practice and how do you consider the patients for treatment versus any other?
I think most of the times, lenvatinib is the drug which is most commonly used in the practice. Majority of patients, they receive lenvatinib.
Yeah.
And then few of the patients, previously they were receiving atezo-bev combination, but now IO is also an option. So few of our patients are now on this combination as well.
Yeah. So I think, yes, now we have some options added. It was initially only lenvatinib or then atezo plus bev. Good point is that we could not start atezo bev in around 20 to 30% of our patients where that was contraindicated. But now we have an option of utilizing the stride regimen, which is a good regimen without any VEGF TKI. Dr. Varun, I would like to get your comment on this. In your practice, when you see a patient with significant varices, though the data is that after banding, you can consider giving bevacizumab, but how confident are you to give atezo-bev combination in such patients? What is your take on that?
So obviously, before availability of durvatrimi, after banding, after managing those varices, we were offering
Yeah.
atizobab, but now we have option of durvatrimi, so we don't take that much risk. So as already have been told that sorafenib is now out of picture. Most of the time, it is lenvatinib only. But
Correct.
if IO patient is fit, PS wise and financially wise also, then IO is also a good option because even if varices at present are in control or grade 1, maybe with time there may be some bleeding even from low risk varices. So if there is no contraindication, so an immunotherapy I am going to give, then IOI is a good option.
Yeah, so I think IO plus has definitely added. And as highlighted, previously we used to take a risk sometimes. After banding, we used to consider atezo plus bev in selected patients after explaining and taking consent of risk of bleeding, because it has happened to us. Even after banding, the patient had significant bleeding and the patient questioned us why bevacizumab was prescribed. Even now we take a written informed consent if we start bevacizumab even after banding. So there are medical legal implications. But thankfully, we have a regimen where somewhat it has become easier, less headache for us. So I will request again comment from Dr. Dheer on this aspect. So how do you see this aspect? Because a lot of our patients are, as discussed, BCLC B and C, where there is a problem. Patients have cirrhosis with a lot of varices. How do you see this combination in the practice?
So I am at the surgical part. So
Mm.
most often, when I receive a patient, either a medical oncologist or a partner gastroenterologist already started. But the people who come straight, I will say majority of them are on lenvatinib, which their drug toleration is very good. We've had some patients in association with Shamsar, where we have had the combination of bevacizumab and atezolizumab, so where we have progressed them. And my aim as a transplant surgeon is basically bridging them from here to transplantation. Whereas, when it receives, the patient comes down to medical oncology, the question is about survival, whether we are able to achieve OS or not. And my aim is basically trying to get them bridging to a treatment where it is a therapeutic treatment. So I think we have succeeded both in a combination, not with alone, where we have also included SBRT, because the challenge we face is portal vein tumoral thrombus along with advanced HCC is there. So we need something more to target that apart from IOIOs and TKIs. That's
Correct,
where my
completely
viewpoint is.
agree. So portal vein thrombosis is a very important problem in all the settings. The patients are many a times not fit for the treatment, and even after portal vein thrombosis, the performance status also deteriorates very, very rapidly, and this is a common problem. So, how in your MDT, how do you incorporate SBRT in such patients? Do you consider starting systemic treatment and then add SBRT, or what is your approach in your MDT, sir?
So my approach is basically, HCC is defined by liver function test, how the LFTs are. If the patient's liver function test and child staging is good, we try to incorporate both together, and we have a set protocol of five fractionated doses where we give them, and this is targeted therapy. And we know that we are bridging this patient towards transplantation. The challenges are ascites. So if there is ascites in these patients, it becomes very big problem for both the modalities, because we are in with diuretics, we are having LVPs, and we are now targeting SBRT. So we definitely start uh, the systemic treatment as soon as possible, and start preparing for the SBRT, and see how the patient is tolerating the systemic treatment. If there is worsening of LFT with the systemic treatment, then it's not a good sign, because then we are not able to, in fact, go to the SBRT protocol, since what are we going to achieve is the question if the patient is not able to systemic. So we always take SBRT as a second stop, not the first stop.
I completely agree. So this is something like bioselection, which we try to do in most of our patients. Start the systemic treatment, see the course, how the patient is responding. If there is a good response to the treatment, then take to the next level, which is most of the time SBRT feasibility. And if the patient is in a stage where transplant can also be offered, definitely this is an option. We have seen a few patients where the patient was BCLC B, but not fit for transplant after starting atezo-bev, and the patient did not have any contraindication at that time. Cirrhosis was not so significant. The patient received atezo-bev and then the patient could undergo transplant as well. So in such patients, after transplant, it is nearly impossible to give immunotherapy. Any comment on that and in your MDT discussion, sir?
We have actually given only lenvatinib post transplant. We haven't given anything. We have put them on a close follow up. One of the patients actually, without our advice, who was on nivolumab, did not tell a transplant team he got a deceased donor liver transplant, and the team was not informed. And I came to know later that the patient had a mortality day 3 post liver transplant, unexplained reasons. So it's a red herring. I think it is to be used. I have not used. I have no experience, but this is what my patient had. Who chose got a transplant done in Bangalore 3 or 4 weeks ago, and I heard about it. So I have only have experience of using zenvatinib. In fact, one third of those, that's only 4 milligram post transplantation, and the patients have done quite well, and we've achieved quite a good OS in these patients.
So it's when the transplantation is in discussion, we need to be very careful in selecting the treatment and also explain the patients about the consequences and the risk and pros and cons of the treatment. So it is very, very important. Moving further ahead, if we see oral OS in the current standard of care where systemic therapy is the only option, I think all of us will agree in majority of the cases in the real world scenario, the OS is below 12 months. Sometimes it reaches between 15 to 18 months, but around if patient is offered systemic therapy only, the majority falls in that area. And this is the data from SHARP trial as well. If you see the median data is to the tune of 10 months. And if we see the REFLECT trial, it is somewhat in the similar area, around 13 months. But yes, first time immunotherapy maintenance, immunotherapy addition, we saw that yes, median is reaching towards 20 months for first time. So, but mind it, these are very well controlled trials with very selected patients, which might not happen in the real world scenario. That is why we might not achieve 19 months in the routine real world scenario. Dr. Namita, do you agree with this statement or any differences in your opinion?
No, I agree with it totally.
Yeah,
I
yeah. So
think 1.5 years is the maximum. I think we can reach only with systemic.
yeah, with only systemic, it definitely limited. So yes, this is what we saw also in a TZOBEV data also. Patients who were Hep C positive, they get the maximum benefit. And non-viral HCC, this is area where we require improvement. Hazard ratio is just 0.91. So in fact, if we, before the availability of the STRIDE regimen, in non-viral SCLC, that is NFLD related HCC, we prefer to utilize even lenvatinib when this regimen of STRIDE was not available to us, because it is clear that in hepatitis related HCC, atezolizumab might work, but in non-viral HCC, atezolizumab doesn't work well. But thankfully, now we have the STRIDE regimen also available, and that is worked well. A very quick comment on Dr. Varun, if you are available. So toxicity of atezolizumab data in your practice, any rapid comment? Or else I will request Dr. Atul.
Hello.
Yes, yes, Dr.
Um,
Atul.
I think we all know the sorafenib we have. I mean, more of this hand-foot syndrome, diarrhea, and with atezolizumab, this hypertension, which is usually cumulative.
Yeah.
So once the lead increases, the risk of developing hypertension also increases, and then few patients have proteinuria. But otherwise, overall, they are better. I mean, well managed.
So hypertension, proteinuria are the most important. Otherwise, most of the time, and this is well managed. So what is the rationale for IO plus IO combination? This is well established. This is not a new concept for medical oncologists because we have been utilizing it multiple cancers in other scenarios as well. In RCC also, we have utilized dual IO from a very long time, and this is the similar combination. Phase 3 Himalaya trial, in which our center was a part of the same. When I was doing my training at TMH Mumbai, we were enrolling patients in this study, and the STRIDE part regimen, actually Durva plus Tremi. The good part is that the CTLA4 is just a single dose, 300 milligram, and Durva is 1500 milligram, and that is also 4 weekly. So it becomes quite comfortable for the patients also to get administrations once in 4 weeks. It is a quite good regimen in terms of patient compliance also because it is single administration. And this is the best part of this. So how do we see this single priming dose of tremelimumab? How do we see this important part? Anybody would like to comment? Yes, Dr. Atul.
I think this is the more. I mean, anti-CTLA-4 is the one which brings the early responses in the stride regime,
Yeah,
and because they start the priming of the peripheral T lymphocytes, and this is the reason I think it is performing better, but giving better results as compared to single agent durvalumab.
completely agree.
On the
So
other hand, if we compare this regime with the Nivo EP, where again we utilize the same strategy, the issue with that is the dose of ipilimumab is 3 mg per kg,
yeah,
which makes you a bit uncomfortable. And then again, four dosages. So toxicity is a concern there. So
completely agree. Completely
I
agree.
think this makes us comfortable that we have just only one dose of tremelimumab, anti-CTLA-4.
And there are patients who are completely agree. Completely agree with that comment. And this is very important to understand. And we need to clearly understand the important aspects related to it. And definitely, the good part is that the data is also very strong. And we have 3 years data, and now we have 5 years data also presented, which has shown significant improvement in terms of outcomes. This is a 3-year OS data, 24 versus 20%. But recently, in last year's conference, and that data has also been published now. The 5-year data has been published. We see 5-year data showing 19 versus 9%. So this is first time we are seeing a 5-year data in advanced hepatocellular carcinoma. So this is quite interesting and important. We never used to discuss 5-year data in SCC because very few patients could reach that mark. But thankfully, with the use of this regimen, I think a very significant proportion of patients are reaching that data. At least 1/5 patients are reaching that part. This is definitely a very important improvement. And good part is that if you could see in non-viral HCC also, this data is very, very strong, has our ratios to the tune of 0.72. So this is very good. First time in non-viral HCC, we are getting so strong data, which has made it important. And one more point is about this LB score that I was trying to highlight. In patients with a good LB score, the response rates are definitely much better. And LB score is very important prognostic factor. And good point is that we have not seen any significant increase in toxicity like in Nivo AP 3 mg per kg, where we were so much worried, as Dr. Atul highlighted, that AP 3 mg per kg is not very well tolerated, and that is why we are not utilizing it. But here we know that it is a well tolerated regimen, and Himalaya data is very, very strong. So I clearly think this is the data in NCC in 2025. It's an approved regimen now, and this can be definitely utilized, and we have started utilizing in important cases. So with this, I would like to conclude that yes, STRIDE regimen has set a new benchmark, 1 in 5 patient alive at 5 years, which is very, very important data. And this is actually changed the way we explain to our patients. So I think we had a nice panel and good involvement of all the panelists. Thank you to all the panelists. We could discuss a lot of important points, including some concepts about transplant. Thanks to Dr. Dheer for his important comments and all the panelists for which very, very interesting discussion. Thank you, everyone. Back to organizers.
Thank you so much, Dr. Akin and all the panelists. So moving ahead for the next session, and I would like to invite Dr. Arun Raja sir, and he's a medical oncology capital hospital Jalandhar, and to give his talk about stride case presentation one, how I treat first line USCC experience sharing IO plus IO. So it's over to you, sir.
Thank you so much, ma'am. I thank Dr. Shyam Agarwal for inviting me and all the organizers and all the panelists who were speaking and highly enlightened by their views. So coming to the real world case presentation. So can you share the slide from your end, ma'am? Please do share the slide from your
Sure,
end.
sir. Just a minute.
So I hope my video and audio are visible and audible. So can you make it in the presentation mode?
Hello, is it fine, sir?
Is it fine, ma'am? Make it in presentation mode, ma'am. Okay, all right, all right.
Okay, just a minute.
Sir, is it visible?
It's visible, ma'am. Please move the slide
Yes,
one.
it's visible.
Yes, okay, okay, all right, ma'am. So, so this is a real world case which I have treated. This is a challenging case for me. I could not forget how they battle for their treatment. So coming for the case proper, he is a 67 male retired army personnel. So he presented us to with the complaints of vague abdominal pain, distended abdominal fatigue. So the history goes like that after his wife death, personal history was an alcohol, heavy alcohol use, and now a reformed ex-smoker, history of vessel bleeding 2 months ago, with a reasonable performance status. Next slide, please. So we did the basic evaluation. What we thought would be a lung cancer with the liver mets, but it turned to be a different thing. So here the lesion is 4.5 centimeter with the extrahepatic disease. So metastatic disease in the lung with no PVT. So child book status A, but subsequently it went to he got ascites. So it upstage to B. Viral markers are negative. AFP was 1000, and the biopsy was obtained because we thought of a lung, so we proceeded with the biopsy. Then it confirmed to be hepatocellular carcinoma by ISC. Next slide, please. So the course in the hospital, he developed subsequently he developed ascitic tapping done, albumin supplemented, and there is a fluctuation of serum ammonia also. In between, high ball was given, refogat, and he had a hepatocancer with the grade 1 and recovered. Next slide, please. So we discussed in the tumor board all voted against immunotherapy. Then patient went back and he had multiple opinions. Reported two after 2 months with CKD. So again, re-evaluation was done. That time, it's not pretty much not treatable, but the family wants best out of best. Again, we discussed in tumor board. This time, the tumor board refused to take a decision. So the family argued with me, why not immunotherapy? So we went back and with the help of our nephrologist, we did a successful dialysis, and I explained the immunotherapy doublets. So we planned the stride regime. He had the first dose in December. Almost the seventh dose of Durva completed. AFP decrease. The level is recent level is 50, and in between having a dialysis that is also going well. Next slide, please. So we didn't go for a local treatment. We stick on with the systemic therapy only. What we did screening for varices and again portal vein thrombosis. We explained whether it is a 28-day protocol or 21-day schedule. So he because of cirrhosis and the alcoholic status, previous varices, we omitted the disobedosis regime. So we stick on with that straight regime, and we are what to say the patient felt better. I also feel that so the decision making depends on the situation, not on the person per se. So what we agree now is if found suitable, all patient of SCG should be given IO drugs. So that's all from my end. Thank you so much. Next slide, please. Got it. So this is a simple case from my end. Thank you so much.
Okay, so thank you so much, Dr. Arunrasa. So I would like to invite Dr. Aditya Sarinza for the next session. It's a stride is a case presentation too. So it's over to you, sir.
Yeah, I think you can pull up my slides now. You have it?
Yes, sir. So can I run from my side?
Yeah, sure. Go ahead.
Yeah, sure. Wait, sir.
So I thank organizers and Sham sir obviously for giving me this opportunity on speaking on this particular topic, and Astra for organizing this on a very short notice. And when we are discussing HCC, I think most of us will agree that the maximum amount of time any metastatic HCC is going to survive is to the tunes of 15 months to 2 years. That is the maximum. Well, obviously, there are outliers, but then again, this is the rough ballpark figure. If they are able to achieve that, we feel very, confident. And but generally, the some stories do end very early, and this is one of those stories where we did something out of the box, and we were able to extend few months of life. So let's dive into the discussion. So next slide. So this is a 35-year-old female who is having a hepatitis B related CLD since 2016, and she's on tablet tenofovir. And obviously, you can see there was no any other history like abdominal pain, fever, blood loss of appetite, weight loss, altered bowel habit, comorbidities, or previous surgery. Next slide. In After 3 years in 2019, during surveillance on ultrasound her abdomen, she was found to have SOL in segment 2 of liver. On further evaluation, she was diagnosed with HCC in segment 2 of liver with elevated AFP, with the AFP of 32 and a PIVCA of 24. And again, she was referred to other center for further management. And on CT, I'll just straight away tell you the MRI findings, which showed a Lyrides 3 lesion with multiple regenerative nodules and Lyrides 2 in the bilateral lobe of the liver. Next slide. And she was taken up for laparoscopic resection, and which turned out to be HCC in the segment 2. Next slide. So this was the final diagnosis in 2019, and HCC in segment 2, hepatitis B related CLT along with portal hypertension, and with child status of A and a MELD of 12. Next slide. And obviously, there was no major operative finding, and patient was discharged post-op day, I think 4, and he continued tablet tenofovir. Next slide. And so this was a case presentation which I did in one of the conference where I asked a lot of people, what about the adjuvant treatment and what is your criteria? So we can skip this. Next slide. And I Am Brave was one of those trials where high risk, criteria patients with HCC were given an adjuvant of atezo-bev. But then again, it's no longer approved, so we can just skip the slide, and it has been taken off the FDA approval as well. Next slide. Next. 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 So obviously, the patient had a fantastic DFI of approximately 5 years. So from 2019, and in December, I think. So now the story will start again. Next slide. So patient presented with below mentioned complaint from 1 month like jaundice, myalgia, and abdominal pain. And considering the previous history, CCT abdomen was done outside. Next slide. Which showed a 10 centimeter lesion involving the left lobe of liver, and post contrast shows early enhancement in the arterial and delayed washout. So one of those classical presentation of HCC on the CT. And another lesion was there in the right lobe of the liver. And next slide. And some free fluid noted in the omental cavity, and prominent nodes like periotic, paraiotic, and mesenteric. Next slide. So final impression was a fairly well-defined mass lesion with internal necrosis suggestive of a recurrent disease with hepatic metastasis in the background, multiple, obviously, minimal ascites, abdominopelvic nodes with splenomegaly, and some pseudoaneurysm. Next slide. So she underwent a liver biopsy, again outside, and she was diagnosed to have a moderately differentiated HCC. Next slide. PET scan was done in the December, which showed lung nodules, again subpleural, and multiple bilateral lungs were involved. Next slide. And you can see now the tumor size has grown to 12 centimeters approximately. Again, the findings were same as that of the CT scan. And on top of that, we just were able to see that, patient was having a lung metastasis. Next slide. Next slide. Next. So this was the presentation where I think everybody can I think you can see the cursor. Can you see the cursor, Gitika?
Yes, sir.
Cursor is visible or not?
No, sir.
Just a second. What about now?
Yes, yes.
Yeah, so I think everybody will be fairly, you can just see how big the tumor was and some of the, nodes over here. So yeah, I think next slide. Just a second. Yeah. So again, it's the same way, the presentation, how the patient presented to us. Next slide. So now she presented with SGRH with all the medical, records, and she further deteriorated in 7 days with tense abdomen and persistent vomiting, almost so that she became PS1 in matter of days. And from outside, she was counseled to go home and on tablet lenvatinib, which she took for at least 1 week and advised for best supportive care. Next slide. So at presentation, she was having a jaundice of 6.6 with the OTPT you can see of 411 and 54, AFP level of 1,75,000, a PIFCA of 25,000. So you can see a massive, massive tumor burden. Next slide. So the final diagnosis was of multifocal HCC with jaundice, obviously being metastatic as it's the scene, you can see it in the lungs, and Hep B related CLD with the Child-Pugh C of 12 and BCLC-D. Next slide. So we were thinking on that lines that whether to treat this patient or not to treat, or shall we just send her for a palliative care? And the relatives' thought process was, that they were not willing for a major signature. So will she make it, or even if she makes it, is she as going to have a troubled quality of life? These are some of the common questions in every malignancy you are going to feel from the relative side, and will take the patient home as patient is having advanced stage cancer. Better to be amongst the family members. Also, that the previous institute has said nothing to do, and obviously there is no hope. Next slide. So when we were to see and go through the guidelines, next slide, I think after taking a complete high risk consent, and I think shifted the patient to MICU and took a completely different and a high risk route as the last life saving attempt. Next slide. So we took a high risk consent of death, and we started the patient of durvaltremi. We told them, this is something off label, and considering the family was giving us the clearance that you do something, we don't want to take her like this to home, and we were very safe before starting this combination. Next slide. And obviously we did tell them, obviously this is not something that we do regularly. And to our surprise, she started to improve gradually over a period of 7 days. And from PS4, she became like PS1 and 2, and no repeated ascitic tapping was required. And jaundice improved, appetite improved. And this was one of the surprise that within 7 days, these drugs were able to work. Next slide. The jaundice, it touched to a level of 2.85. It didn't go below that, and it was static for a few months. Next slide. And any guesses for the AFP? I generally ask my audience, so here I think I can just go ahead. So the AFP levels were, Gitika, next slide. It turned out from 1,75,000 to 3,131. Next slide. And again, the patient was given second dose of Durva in January. Patient tolerated well, discharged. And again, the patient was planned to follow for after 3 cycles. Next slide. So I think I will just tell you what happened to that patient, that in till Feb, she was able to receive 3 cycles of Durva, and we were able to give 3 months of PFS benefit, where only, she was going to survive maybe for a week or so. And in March, we lost her. But then again, at least from a scenario which was non-salvageable and where she had a lifespan of hardly 10 days, because when she presented to us, she was completely PS 4.5. And she did well, at least for 3 months. And patient's family were very happy with the fact that at least we did something, and it did change, not to a great extent, but some benefit was there. And obviously, we all know cross-trial comparison are not required, but still, for the sake of it, you can see the OS of IMBRAVE 150 along with the Himalaya. And again, the benefit is to the tunes of 19 months and 16 months. Next slide. And you can see the side effect profile. Himalaya has a relatively less side effect, considering there is no use of bevacizumab. And proteinuria is also rare, fatigue is also rare. And so there is a higher chances of immune-related adverse events because of the dual IO-IO combination over here. And diarrhea was also reported in 10 to 12%. So the key benefit with IMBRAVE 150, patients needing high OS benefit, tolerating BEV-related bleeding risk, and Himalaya we can select for patients unsuitable for TKI or at risk for bevacizumab toxicity. And STRIDE regime approved is approved one, and it has less adverse event burden. Long-term immune memory concept can be applied. But the IMBRAVE 150, you can see a benefit of OS and PFS, but the only limitation over there is the bleeding risk. And next slide. So yeah, I think this is the only protocol where you can have a chemo-free alternative in terms of an IO-IO combination to TKIs. So I think next slide. And with this, back to organizers.
Okay, thank you so much, Dr. Aditya. So, is there any questions? So, please keep in chat box. So, moving ahead for the session 2. So, session 2 is a from evidence to action, transformative approaches in BTC management. So, I would like to invite Dr. Mosmi Suryavanshi, and she is in Amrita Hospital, Faridabad. She's a molecular biology, and to her talk about precision oncology for biliary tract cancer, why molecular testing matters. So it's over to you, ma'am.
Yeah, good evening, everybody, and thank you for this invite. I would like to share my slides. Can you see my slides? Can you see my slides?
Yes, ma'am. Make full screen, please.
Yeah, please, just a second. Okay. Okay, I will be talking about precision oncology for biliary tract cancer, why molecular testing matters. Okay, so before we go on to the molecular testing, so just look at the anatomical classification of biliary tract cancers and what actually comes under the biliary tract cancer tree. So the intrahepatic region, which is there are and then there is an extrahepatic region, which is either hilar or which can be a perihilar, or it can be the extrahepatic distal region, or it can be gallbladder, and then it can be the distal bile duct part, which is the ampulla of Vater. So basically, under the umbrella of biliary tract cancer is intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, which can be perihilar or distal, gallbladder carcinoma, and ampulla of Vater. So the next question is, since they are all connected, are they all the same? So let's go to the etiology. So if you look at the etiology of intrahepatic cholangiocarcinoma, they are choledochal cyst, cholelithiasis, cirrhosis, hepatitis B, C, alcohol, IBD, smoking, etc. And if you look at the etiology of extrahepatics, there, of course, most of them are common, but there are some liver flukes which are associated, especially in the Southeast Asian countries. And if we look at gallbladder, which is pretty endemic to our part of the world, there are various risk factors which have been predisposed, like the gallstones, some primary biliary sclerosis. Some have also stated that tuberculosis could be a cause, then salmonella could again be a cause, and then of course there is a genetic predisposition and then risk through aflatoxins like fungi. So, and also the gallbladder cancer is known to be more predominant in female vis-a-vis the cholangio, which is seen more in males. So definitely there is something etiology-wise which is different in all these cancers. So why so much interest in biliary tract cancer? So they have been there, but there's sudden interest now in biliary tract cancer. So the thing started changes with in around 2017 when there was approval for a lot of chemotherapy and the molecular therapy drugs. And almost each year since then, there has been approval, and now we have a lot of molecular targets which are available, starting from the agnostic approval for MSI or NTRK to the IDH1, the FGFR2, and HER2 now, they have been approved. So what is the treatment landscape presently? So presently in the first line, it is either chemotherapy plus immunotherapy, which is the main gold standard for all these tumors, and which gives a overall survival of around 12 to 13 months. And in the second line, conventionally it was FOLFOX or FOLFIRI, with an overall survival of around 6 to 8 months. And where the game has changed is if the molecular targets are present and they are offered. As you can see that there could be FGFR fusion, IDH1, BRAF, etc. And there is lots more survival advantage over the FOLFOX advantage of 6 months. In FGFR2, it could be up to 22 months, in IDH1 up to 10 months, and BRAFs again 14 months if MSI high, up to 2 years, and HER2 around 15 months. And then there are some newer targets like KRAS G12C. So, okay, this is again the same thing, just to mention the drugs which are available for the various molecular targets. And you can clearly see that the survival from 6 months is definitely more if you find a molecular target. So that is where the game has changed in biliary tract tumors. So these are the mutational profiles. Since we were looking at the etiology, we realized that it was not a same tumor. So let's look at the mutational profile. This is the global data. So if you, as you can see in intrahepatic cholangiocarcinoma, the commonest mutation fusions are FGFR2 fusions seen in around 9 to 14% of the patients. Then are IDH1, which are around 10 to 29% of the patients, then BRAF, HER2, KRAS, ARID1, and so on. And vis-a-vis, if you look at the extrahepatic cholangiocarcinoma, which is very close to that region, but it is, and the extra hepatic part, the mutation, there are hardly any mutations found in the, or fusions found in FGFR2. Rarely we do find in IDH1, BRAF, HER2, and the predominant mutations are again KRAS there, and other mutations are there, but the frequency is lesser. Now looking at the gallbladder, which is again very different, FGFR2 are rare again, IDH1 is also rare. So what is predominantly seen here is HER2. HER2 is seen around 6 to 15% in various population, and other mutations are less. Though the mutations are same, but the frequency of mutation is quite varied in these populations. So based on that, there is two types of molecular approaches to molecular targets in biliary tract cancer. So one is the target specific approach as seen in cholangiocarcinoma, more so in intrahepatic cholangiocarcinoma, the commonest being FGFR2 fusions and IDH1 mutations. And then there is the basket trial kind of approach where there are agnostic markers like BRAF, HER2, MSI, NTRK, and RET, which are found across, could be found across any of the tumors, and the same drug could be offered to them. So overall, there are multiple targets now available in the biliary tract tumors. So coming to the FGFR2 fusions, which are seen, which is the commonest in intrahepatic cholangiocarcinoma, and there are around 50% fusions are seen, but they are 5% of the patients. And there are around more than 150 fusions which are seen. And these fusions are mainly enriched in the population where the cholangiocarcinomas are caused by non-fluke associated etiologies. So they are unlikely to be seen in the South Asian, East Asian countries where the commonest cause of cholangiocarcinoma is because of the liver fluke. So they are more reported in the Western literature where there is not a fluke association with cholangiocarcinoma. And also these are mutually exclusive, like your lung cancer, most of your EGFR, ALK, etc. are mutually exclusive. So these are also mutually exclusive with the other somatic alterations like your KRAS, HER2, IDH1, etc. So again, these are the inhibitors which are present, and you can see the overall survival rate is 35%, and the disease-free survival 82.2%. And similarly, in this other infigratinib, also there is around 83.3%. And there are many more new FGFR inhibitors which are on the way. And this is around IDH mutations. So IDH mutations are the second commonest in intrahepatic cholangiocarcinoma. So these are they are because there could be IDH1 or IDH2 mutation. They are basically increased 2-hydroxyglutarate, which is associated with a higher DNA CpG methylation and altered histone methylation. So it is because of the methylation, IDH1 is far more than IDH2, and the drug is also available against IDH1, which is commonest is R132C and also R132G, against which the drugs are available. And again, like your FGFR2, this is also mutually exclusive, but can coexist with BAPI1 mutations. So, and we have this drug idosininib, which has a survival benefit of around 10 months compared to Folfex, which has a benefit of around 6 months. Then again, there are agnostic markers like your BRAF, your HER2, MSI. So these are also there, which I think we know, NTRK red. So we already know about them. So I will not spend more time on them. And then these are one size fits all marker, agnostic marker, tumor mutation burden. So I don't know, it really applies to all the tumors, but yes, we do have a FDA approval for a tumor mutation burden more than 10 mutations per megabase for the use of immunotherapy across all the tumors. So then now what there are other actionable biomarkers, which though I think maybe in the first line you may not think about that, but maybe if they are present, there could be a chance to use KRAS G12C, which actually you can use BRCA and other DNA repair mutation, PIK3 mutations. So these could also be used in the maybe third or fourth line settings. So this is, I'm sharing our experience. So this is the story of from 2 years back, I think in 2022, end of 2022. So when I had shifted my institution, and then I met Dr. Javle, and then we thought, we realized that there was hardly any data from India. And we then thought of compiling the Indian data, and this was a collaborative project of 6 institutes initially, and where Tata, us, and a lot of other private labs also, including the Army Hospital, also shared their data, and we presented their data and at the Asia Pacific Cholangiocarcinoma conference. But then it was thought that it should be published, and then as we were collating the data, we realized that it was a huge data, and gallbladder was endemic in our part of the world, and we had to separate the gallbladder from the other the cholangiocarcinoma. And this is our first paper, which has been accepted in JCO Global Oncology. And in this paper, what our findings are. This is again data from Tata Memorial, our data, and also from other institutes and private labs also. So this is around 376 cases in the span of 2 years, with the median age was 54 years. And the age was a decade earlier than the global cohort. And as expected, there was female predominance, and the key genomic findings were TP53 around 54%. So that was the predominant mutation. Then HER2. This includes the amplifications mute as well as the mutation was around 15%. And we just looked up, there was very scant data about India, even though gallbladder is endemic. And there were various percentages of HER2 which were reported, but the amplification stands around 7%. So this is a combined thing. So HER2 is 15%. Then there was CDKN2A and KRAS and SMAD4 mutation, along with some other mutation. As expected, MSI was not was only seen in 0.6%, and TMB high was also seen in 1.3% of the data which we had collected. So HER2 amplifications were more common in India, and we compared our data with the C-Bio portal data of almost the same number, 396 patients from America and of various ethnicities. And we did see that our mutations were more common with the Asian ethnicities. And we also had some 37 patients for which liquid biopsy results were available, and these mirrored the tissue trends. So definitely this is a big resource from our country, and it also lays the foundation of many other studies which will be conducted on this. Then the second part of our this endeavor was to publish about the cholangiocarcinoma, our variations in Indian population, and this also has been submitted to Lancet and is about to be published. And so what was difficult in this case was that there were lesser number, of course, of cases compared to the gallbladder cancer. And unlike the Western populations, our data was not segregated well into intrahepatic, extrahepatic cholangiocarcinoma, but we were able to get some clear-cut diagnosis of intrahepatic cholangiocarcinoma. These were 147 cases. Again, TP53 mutation was the commonest, and IDH1 in our population was around 9%, and KRAS was 7 to 9%, and PIK3CA was 7.9%, which were frequently mutation. And in our population, TP53 and KRAS were in higher percentage compared to the Western population, what we saw. And our FGFR2 fusions, which were predominant in the Western populations, were lesser. In fact, we had some amplifications, but our fusions were lesser. And this would also be because of the fact we had used three well-validated NGS panel, one from Sophia, TSO 500, Oncomine 500 gene, and Oncomine 161 gene panel. So, and even foundation data was there. So most of the panels, though, were very well validated and globally known NGS panels, but still they could have some difference in frequencies. So we did collect this data, and we are expecting it to be published soon. And as you can see, this is the cholangiocarcinoma data with the mutations TP53 36%. Then we had some fewer cases of around 61 cases of which had a clear-cut diagnosis of intrahepatic cholangiocarcinoma, which also almost mirrored our combined cholangiocarcinoma diagnosis. Again, TP53, IDH1, and KRAS were the commonest mutations there. And then there were rarely BRCAs and HER2s also, which was present. Again, fusions were lesser as compared to the Western population. We had very scanty data, almost 10 cases of extrahepatic cholangiocarcinoma, which were there. And age-wise, these were a decade older than the gallbladder cancers, which we had seen, and they were more predominant in men. And in comparison to the Western population, also our frequency in men were more. So these are This is just a comparison what we did of our mutation in TP53 versus the C-Bio portal or the Western data, and we compared. Most of them were same, and again in the KRAS G12D was the commonest mutation in our population as well as in the global population. And then there were these PIK3CA, which was more in our compared to the global. And you can see that IDH1 was 9% in our compared to 12% in the Western population. And BAPI was 5% in our population compared to 13% in the Western, and SMAD for mutation were lesser, 3% compared to 8% in the Western. Same for ARID1 was significantly different. In fact, it was the same in the gallbladder as well as the cholangiocarcinoma, and I'm not really sure it could have been a panel to panel variation also, but the other findings I think were quite significant. So this is just to show you that cholangiocarcinoma is different when the etiology is different, the fluke versus the non-fluke. The patients who have the etiology as liver fluke, they have different more of TP53 mutations and more of BAPI1 mutations compared to the other non-fluke ones, which have more of the FGFR2 and IDH1 fusions. So definitely the profile is different. And coming to the role of liquid biopsy. So again, since this has a lot of molecular targets, the role of liquid biopsy cannot be ignored. And it is a difficult to biopsy area also. There are quite a number of cases when we are not able to biopsy these patients. And that time the bile fluid or some lavage kind of thing can be a useful resource of detecting the mutations. And these are some studies which I have just quoted, where you can see that a guideline recommended biomarker shows that 18% of the population out of this study of 1,495 patients, they were able to find mutations or fusions or biomarkers. Okay. This is another study of around 1,671 patients on the Guardant cell-free DNA, and it found that genetic alterations were detected in 84% of the patients. And the rate of detection for FGFR fusions was lesser compared to the tissue, vis-a-vis IDH1, which was and BRAF, which were almost as good as which were diagnosed in the tissue. So this is the similar finding which I also have seen in my clinical experience. It is slightly difficult to detect the fusions in cell-free DNA. You do detect them, but it is the chances are lesser compared to what you do on tissues. But the mutations, if they are present and if they are shed, are easily detectable. So these are the same findings you can see here. And this is again the same thing which has been depicted pictorially. And you can see the cfDNA, FGFR2 fusions are lesser, picked up in the lesser range. And IDH1 is almost is picked up well. So then another useful resource besides the blood is the bile, which is also there are very few studies done on the bile, and which can be used not only the blood samples, the plasma samples, but so the bile samples can be used in some clinical situations. And the few studies we have shown a very good concordance. So you can see here 99.1 versus 78.3%. With a very good p-value. So this can be used in certain clinical situations. And with that, I will like to thank you for your attention. And if there are any questions, I'll be happy to answer.
Okay, thank you so much, Dr. Masoom ma'am, for the great presentation. So, moving ahead for the next session, and I would like to invite Dr. Aarti Malhotra, and she's a medical oncologist at Ganga Ram Hospital, and to her talk about our gallstone suppressor of gallbladder cancer. So, it's over to you, ma'am.
Ma'am, you are on mute. Please unmute yourself.
Yeah, am I audible? Yes, ma'am. Yeah. Can I have my slides, please?
Yes, ma'am. Just a minute.
So at the outset, I'd like to thank Shyam sir for bringing me here to this platform and discuss association of gallbladder cancer with gallstones. So I'll just walk you through these slides where I'll be covering the epidemiology, the risk factors, the evidence, whether gallstones are actually have a causal association with gallbladder cancer, or they are actually just confounded by other cofactors. Can I have the next slide, please? Yeah, the next. Next. So, biliary tract cancers in India. So we have approximately 31,000 cases of biliary tract cancers, which includes gallbladder cancer. Gallbladder cancer per se is not a very frequent malignancy in the Western world, but here in Indian subcontinent and probably Chile is one of the places where this disease is more prevalent and has higher incidence. So the crude incidence in gallbladder cancer and biliary tract cancer in females was highest in the states of Assam and Delhi. 90% of the biliary tract cancers are diagnosed as unresectable, and we've seen that they come as a locally advanced disease where we have to forego the surgery and plan a neoadjuvant chemotherapy or just palliative chemoimmunotherapy. Patients currently as standard of care based on the ABC2 trial, gemcitabine and cisplatin became the standard of care, where from no treatment to some treatment in form of chemotherapy had improved survival to about 6 months of time. Now, however, we have immunotherapy as per the Topaz trial. Durvalumab has been added, and we're seeing better results. Seeing Shamsa's OPD, I constantly see patients doing very well. Now, I mean, in where the locally advanced unresectable malignancies, I've seen 3 cases where patients have undergone surgery and are doing fine. Next slide, please. So apart from gallstones, what all factors have been associated with malignancy? Since our MBBS days, we've heard the 5 Fs for gallstones, which are fat, 40, fertile, female, fair. So this probably holds true in gallstones, which actually is one of the causal factor for gallbladder malignancy. The other factors being diabetes, which again is a immunosuppressive kind of a state, or I would say a chronic inflammatory state, which exaggerates the inflammation that is being put on set by the gallbladder stones. Then we have biliary tract infections, where we have parasitic infections, and of course obesity is one major cause. Next slide, please. So gallstones are more prevalent in gallbladder cancer in comparison to the cholangiocarcinomas. Cholangiocarcinomas, CBD stones would probably lead to a cholangiocarcinoma rather than a gallbladder cancer, and gallstones per se are present in about approximately 70 to 90% of the gallbladder cancer. However, the overall incidence of patients with uh, cholelithiasis is only 0.5 to 3%, which would actually develop and lead to a gallbladder cancer. So gallstone association is still unknown, and it still retains as a dilemma whether it is confounded with other factors, the ones that I have spoken earlier, or it is has a direct causal association. Next slide, please. So this is actually this relates to this slide is suggestive of the pathogenesis. So any malignancy we've seen is there's a chronic inflammation. So gallstones would irritate the gallbladder mucosa, which would lead to chronic inflammation.
Inflammation would lead to metaplasia. Metaplasia would lead to dysplasias, and then ultimately anaplasias. So we have gallstones, dysplasia, carcinoma in situ, and then frank carcinoma. And the genes that are associated is T53, COX2 overexpression, methylation, epigenetic changes, and KRAS mutations, categorically seen in gallbladder and cholangiocarcinoma. Next. The dilemma still existing. We'll see in the next slides whether we can actually decipher between whether it's a confounding factor or a cofactor. Next, please. Next. So, this study where the role of gallstones in gallbladder cancer in our subcontinent was conducted at TMC. Patients were enrolled in the Department of Surgical Gastroenterology, and there were about 1,125 patients of gallbladder cancer versus 2,525 controls. So the subjective measurements that was made was based on the self-report, the history taking, and the questionnaire. And of course, the objective response was based on images as it is done in OPD basis. Next. So here we can see the presence of gallstones in gallbladder cancer. Patients who had self-reported, there was a stringent definition that was defined as all self-reported cases, minus the exclusion was done for patients that had been diagnosed within 1 year of gallstone and malignancy, or the interview was conducted within a year's time. So we had 12.4% patients, and those that were self-reported gallstone history was 40%. We can clearly see the female preponderance, where 2/3 of the patients were female and 1/3 were male. Geographic distribution, we can see the northern, the gigantic belt is often affected and been reported in multiple studies. So north and the northeast, like I had discussed, Delhi and Assam were the states which had the maximum number of cases. Next, please. So here we can see the odd ratio of gallstone ever being reported was 10%. And the confidence interval is, of course, here 95%. And where self-reported with the stringent definition that I had spoken of, was with exclusion criteria of them being reported within a year of malignancy or within a year of the interview, was 4.5%. Then imaging based, it was only 2%. Next slide. So this was again a study conducted by Mohapatra et al. It was a sequential occurrence of pre-neoplastic lesions and accumulation of loss of heterozygosity in patients with gallbladder stones, suggesting any association with gallbladder cancer. So this suggested that the gallbladder specimens of patients with gallstones were examined with pre-neoplastic lesions and the loss of heterozygosity. Like we've seen that there has to be two hit phenomena to actually, for it to culminate into a malignancy, where various microsatellite markers and in the pre-neoplastic lesions were assessed. Gallstone patients had high frequency of these pre-neoplastic lesions and accumulation of these loss of heterozygosity, LOH, and possibility of these leading to tumor suppressor gene, wherein the activation of the malignancy cascade led to gallbladder malignancy. Next, please. So here we can see gallstone association, the pre-neoplastic were approximately 64.8%, metaplasia seen in 24.6%. Categorically to be noted here is carcinomas in situ, that is frank malignancy, was seen only in 0.6% of the patients. Metaplasia and dysplasia, of course, was 12.6 and 3.4 respectively. Hyperplasia, metaplasia, and dysplasia were seen in 4.3%. Next. So here we've seen whether the evidence favoring the causative role of gallstones to GB malignancy. Now we'll come to discussion on whether these evidences are, actually not corresponding to malignancy, but rather a cofactor or maybe a confounding factor, which we've been dealing with a lot of biases statistically. Next slide. Yeah, sorry. That's it. So gallbladder cancer is multifactorial disease. We know we've seen gallstones and infections may lead to malignancy due to chronic inflammation. And only 1 to 3% of patients with cholelithiasis patient develop gallbladder malignancy, and the frequency of Indian GBC patients with gallstone is reportedly, as spoken earlier, is 90%. Not all patients with history of gallstones actually develop malignancy. Next, please. Next slide. So here we can see the relative risk. So what all in a gallstone would actually increase the risk of them culminating into a malignant potential. So size would vary. Any size of more than 3 centimeter gives a higher risk, more than 3 times than when it is less than 3, which is like 9.2 to 10%. Then duration of gallstone, any gallstone sustained, present in the patient with a history of more than 20 years would of course be of greater risk. A BMI of 30, which is obesity, as per the guidelines, is again a risk factor which increases the relative risk, where here the risk is more in female than the male counterpart. Infectious diseases, typhoid and other helicobacter infections can also be one of the relative risk for the malignancy of gallbladder. Next slide, please. Next. Yeah. Thank you, sir. Can you go back? So accumulation of gallstones for about 20 years increases the risk. However, this risk has not been associated in younger patients, patients of the age below 45 years of age. And causality is again still not established, though it holds a good chance that gallstones have a strong association with gallbladder malignancy. Next slide, please. So this is again a study conducted by Kajal Jain et al. So it was a case control study done between gallbladder malignancy cases with gallbladder stones versus those controls which did not have stones. So again, the association was seen, and there were other factors that had shown, as per the odds ratio, that fried foods was contributing to the malignancy. Tea and coffee did not show any association. Chemical exposure, yes. Tobacco use, yes. And family history was not very, very corresponding. Coming to the summary, the next slide, please. So the take-home message would be gallstone is the strongest risk factor, of course, but then the temporal association has still not been established. And I think we are on the next slide. The last slide, please. Yeah. And so still early detection and early identification of gallstones and cholecystectomy as a prophylactic management for buying the lead time bias for any patient having gallstone for more than maybe 20 years can probably be a preventive measure for gallbladder malignancy. Like we know that usually gallstones are resected, gallstones are surgically removed only once they are symptomatic. But if prophylactic surgery is done when patients are not symptomatic, probably we can prevent gallbladder malignancy. Thank you.
Thank you so much, Dr. Aarti ma'am. Is there any question? Please keep on chat box. So moving ahead for the next session, and I would like to invite Dr. Shyam Agarwal sir, and he's a medical oncologist, Sir Gangaram Hospital, and to give us talk about checkpoint inhibitors meets chemotherapy, the involving treatment front in advanced PTC India RWE data. So it's over to you, sir.
Yeah, thank you. So can you share the screen, the slides, please? Right. So as you just heard, chemotherapy used to be the mainstay of treatment for patients with advanced unresectable biliary tract cancers. But now is the era of immune checkpoint inhibitors, and things have really evolved very rapidly in the last 5 years or so. Next slide, please. So that's the outline of the presentation. Next slide. So we're running late, so I'll try and conclude in a few minutes. So I think these data are already shared. The number of cases in India still remains a fatal disease. And that's the prevalence rate, 36,000 people at a point in time. Next slide. So these are the statistics from GloboCan. And again, you can see the number of cases, which actually continue to increase over a period of time, like all other cancers. Next slide. And I think this is already shown that these are some, the, uh, the Ganges belt, where you see a high incidence of gallbladder and biliary tract tumors. Bihar, for example, UP. So these are two very, very important areas in India where the incidence of gallbladder malignancy is extremely high, maybe even number one in Bihar. Next slide, over and above breast and cervical cancer. So the age, as you can see, is 40.5 years. Next slide, or even beyond. Next. So these are, the statistics for the 25-year data. And as I said, the numbers are gradually increasing. Next slide, it's not visible clearly. Next, please. Most of them are females, as you saw. So let's come to the meat of the discussion. Immunotherapy as first line in advanced BTC. So this is the Topaz 1 study where they had nearly 690 cases, equally divided between Gemcis versus Gemcis and durvalumab. And they had all types of biliary tract cancers where intrahepatic, extrahepatic, and gallbladder malignancy were included. So the dose of durva was 1500 milligram every 4 weeks, and Gemcis was given on a day 1, day 8 basis. Next slide. So this was the primary endpoint, which is the overall survival, which is what we all aim for in cancers. And as you can see, at 12 months, 54% versus 47%, and the hazard ratio is 0.71. 18 months, 34% versus 24%. And at 24 months, nearly 1/4 of the patients are alive at 2 years. So, which is a major landmark in gallbladder cancer as compared to 11% with chemotherapy alone. And the hazard ratio is 0.76 for the overall survival. So this is a study which was initially, when it came in, because of the minor differences in the study, at 2 years was criticized. But then this is been now accepted as a major achievement after many years over and above chemo alone, and has become the standard of care for patients with biliary tract cancers. Next slide. So this is the progression-free survival. at 12 months, 16% versus 6.6%, and the hazard ratio is 0.75, which is significant. The median PFS is 7.2 versus 5.7 months. Next, please. So almost 1/4 or more patients will have an overall response. Most of them are partial responses, 25% plus 2%, and the disease control rate is 85% with the chemo-immuno arm. And the duration of response, again, 6.4 months with the immunotherapy versus 1.6 months. That is the median time to response. So these patients do respond fairly quickly within first two cycles, I would say, most of the times. Next slide. And patients who respond, meaning thereby that patients who achieve a CR or a PR, I mean, you can see the curves plateauing, and at 2-3 years or so, almost 40% patients are going to be alive. So that's the overall survival data. So this is an important consideration, that patients who get a CR, PR, and here the hazard ratio is 0.69. So almost 25% patients who achieve response, 40 or 50% of those will be alive at 3 years or so. Next slide. So this is again just show the previous slide across the several presentations. You can see the benefit of the protocol in majority of the areas. Next slide. So the side effects are not too many. I think we are all now becoming familiar with the immunotherapy related toxicity, and it's only 9% patients where you had to discontinue the drug because of the side effects. Next. So there's not much increase in the bone marrow toxicity, although, so it's virtually similar. Next slide. So the 3-year overall survival data from Topaz 1 shows, the hazard ratio is sort of maintained at 0.74, and at 36 months, 15% patients are alive as compared to 7% when you look at the ITT population. So therefore, patients who were not going to be surviving, long-term survivors have become a reality with the durvalumab gemcis combination. Next slide. So again, this is the same data here in the curve fashion. Next slide. So overall, at 12 months, at 24 months, and at 36 months, you can see more and more patients, almost doubling of the patients, surviving. Next slide. Next slide, please. So as you heard Dr. Mashmi, these are the genomic alterations in biliary tract cancers, and you can see P53 standing out, 48%, followed by the MTAP loss or CDKN2A, KRAS and ARID1A, SMAD, IDH1. So, this is the profile which was told in detail. Next slide. So what is the impact? And these are the genomic alterations by the tumor location, which were discussed in great detail by Dr. Mashmi. Next. So the question is, next slide, please. So are there any mutations which do worse or which don't respond well to chemo and durvalumab? So if you see P53 here, you see the CDKN2A, you see KRAS, you see ARID1A, IDH1, ERB2, which is fairly common in gallbladder cancers, BRCA1-2, FGFR2. So the generally similar overall survival benefit durva versus placebo was observed for participants with either wild type or altered genotypes. So, when you see a patient with ERB2 or HER2 amplification, do you jump onto trastuzumab or some other drug? So the first line treatment still remains Durva, Gemcis, and one can use other agents in the second line depending upon the target which is found in these patients. So irrespective of the genetic makeup of the tumor, chemo Durva remains the treatment of choice. Next slide. So these are several studies which have demonstrated the efficacy of Durva Gemcis in the real world setting. Next slide. So from Italy, next. So there are several studies. Next, please, we'll just rush it up. So there are 145 cases. Majority of these are cholangio. Next. So you can see 12.9 months is the median overall survival in the real world setting as compared to chemo alone. Next. It seems to improve the overall response rates, 30%, and even complete responses to the tune of 5%. So we've taken advantage of this response rate, as was mentioned in the previous talk. We had patients where the disease was unresectable to begin with, and almost out of 15 patients, we could convert them into resectable disease. And actually, 4 or 5 patients have undergone R0 or R1 resection. So, that's also becoming a reality now with the combination of chemo and Durva. Next. So I think the safety profile is well known, but we are seeing unusual side effects. Some people having muscle involvement like myositis, some people having acral dactylitis. So you have to keep an eye on thyroid and other hormonal disturbances. Next slide. This is another Italian real world data. You can see 666 patients and see the curves, in favor of the combination. Next. So just skip the slides. Next, please. From India, Dr. Vamshi Krishna, he pooled data on 148 cases. Next. Different centers were involved. Next, please. Next, please. This is the age, and you can see complete response rate of 2% and a partial response. So it's kind of being reported from all across the world, a response rate of around 30%. So which is quite incredible. Next.
Dalry.
And that's the progression-free survival, 8.2 months. Next. And the overall survival is almost 12 months. Next, please. So some pneumonitis, thyroid, skin reactions due to the drug. Next. So I think overall, as we see, the real world data supports the Topaz-1 trial data, and disease which was actually very, very bad after the availability of immune checkpoint inhibitor durvalumab has seen, in my practice at least, dramatic outcomes in some of these patients, and they're expected to be long-term survivors in up to 20% or even more. So that's really very encouraging. Next. Next. So I think not to go into the details of this. So you do have the other combination of Pembro. But then since Durva is approved, we are using as a first line treatment for all comers along with cisgem. Next, please. Right. So this is I think the NCCN guidelines today. And the second line, as was discussed, FOLFOX or irinotecan-based combinations can be used. And then, of course, we have a whole lot of these targeted agents which were discussed before. Next. So I think we've covered most of these things: long-term survival, safety, response rates, irrespective of the genetic makeup. The DCGI gave the approval for Imfinzi along with GemCis in first line. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Shan sir. So moving ahead for the next session and the last session, and I would like to invite Dr. Abhishek Anand sir, and he's a medical oncology Paras Hospital Patna, and to give us talk about Durva plus chemo, BTC real world case presentation one. So it's over to you, sir.
Hi, good evening. Can you allow me to share the slides? First of all, I would like to thank Shyam sir for this opportunity, and I'll be speaking or discussing one of the case of biliary tract cancer. If we talk about the biliary tract cancer, as Shyam sir has already explained much about the first line management, the stats from NCRP reports more than 30,000 cases of BTC, including gallbladder cancer, and 90% of the biliary tract cancers are diagnosed in the unresectable or advanced stage. Unfortunately, the median OS remains poor, dismal in the advanced stage, and the 5-year OS rates is still less than 10%. Cholangiocarcinoma have got a high incidence in Asia, notably in Northeast Asia and Indochina. And North India has one of the highest incidence of gallbladder cancer. So coming directly to the case, the 60-year lady presented in February 2023 with jaundice for 2 months, itching over the body for 1 month, and generalized weakness along with abdominal discomfort for 15 days. And patient was having a general condition poor, ECOG performance status of 2. Icterus was present and liver was enlarged 6 centimeter below the costal margin, which was hard and nodular. Routine investigation was done, which was all within normal range except the serum bilirubin, which was deranged, and it was 19.58 milligram per deciliter. So CT scan was done, which was showing asymmetrical enhancing thickening of gallbladder wall in the fundus body and neck region that was infiltrating the mid CBD with a dilatation of proximal CBD, CHD, and bilobar moderate IHBR dilatation with multiple enlarged lymph node at porta hepatis, peripancreatic, para-aortic, aortocaval, and paracaval regions, and moderate hepatomegaly with a few mildly enhancing regions in the caudate and segment 8 of the liver. So this is the CT scan of the abdomen, and you can see here few hepatic metastasis, nodal metastasis, and the gallbladder lesion as well. Endoscopy was done, and there was a stricture at D1 D2 junction. Endoscope could not be advanced due to the stricture, and control radial expansion with balloon dilatation was done for the stricture. USG guided biopsy was done, which was suggestive of adenocarcinoma, moderately differentiated, and we did the PTBD on 3rd of March 2023, and serum bilirubin fall down to 2.6 milligram per deciliter within 20 days, 23 days of PTBD. So these are the ESMO guidelines how to approach a case of BTC, and we already have explained that it is very important to take the opinion of multidisciplinary team, because all the specialty are important in defining the exact treatment option for the biliary tract cancers. So coming back to the case, this was April 2023. Patient was planned on durvalumab along with gemcitabine and carboplatin, and it was the day 1, day 8 of carboplatin and gemcitabine on day 1 with durvalumab on day 1, and the dose being the standard as the Topaz trial. It was 1500 milligram. So this is the ESMO guidelines how to approach advanced biliary tract cancer patients. So molecular profiling and gemcitabine cisplatin with or without durvalumab or pembrolizumab has been the standard of care and category 1 recommendations. Genetic alterations have been seen in biliary tract cancer, and these are the common genetic alteration which we see: HER2 amplification, BRAF, KRAS, PIK3CA, FGFR1 to 3, then IDH mutations, and it is very heartening to know that we have got a few targeted agents for these mutations as well and have been approved in the biliary tract cancers. So immune checkpoint inhibitors and the biliary tract cancer and their mechanism of action, we all know about these. So TOPAZ-1 study, this is the study based on which we started durvalumab along with gemcitabine and platinum, and this has been already discussed by Shyam sir. It was a phase 3 trial, and randomization was done to receive either durvalumab along with gemcitabine cisplatin for up to 8 cycles versus placebo with gemcitabine and cisplatin, and it was followed by durvalumab, which was given every 4 weekly in the durva arm and placebo every 4 week until the disease progression. Primary endpoint being the overall survival. If you see the overall survival data, the median OS was 12.9 months in the durvalumab arm, and it was 11.3 months only in the placebo arm, and the difference was statistically significant. If you see the 3-year overall survival data, it was more than double, 14.6% in the durva arm and 6.9% in the chemo only arm. Another important thing is that, which was very well highlighted by Shyam sir, that patient who responded continue to respond better, and there are a number of patients, around 20 to 30% of the patients who respond very well to durvalumab combination, and they are long survivors as well. So this is the PFS data, and the PFS was also better for the durvalumab arm as compared to the chemo only arm. So the CT scan was done post 4 cycle of chemotherapy along with durvalumab. There was a partial response, and ERCP with metallic stenting was done for this patient. PTVD catheter was seen and structural dilatation was done. PET scan done after another 4 cycle. There was a near complete response. There was no evidence of viable tumor in the gallbladder, and only a faintly FDG-avid aortocaval lymph node was seen. Real world data has already been elaborated by again Shyam sir. These are the data from different parts of India, and the conclusion from the real world evidence experience shows that this real world evidence mirrors the survival data from the Topaz trial. Again, we did the PET scan after 6 months, and it was in April 2024. There was no evidence of any viable tumor or metastasis, so it was deemed as a complete response to the therapy. So this is the last evaluation, October 2024. Patient was on complete response, and patient is still continuing on the same agent, and patient is still on complete response, and durvalumab maintenance has been given to the patient till now. So the real world experience suggests that durvalumab at a dose of 1500 milligram in combination with chemotherapy continues to have responses and outcome that is similar to that seen in the Topaz-1 study. With this, I would like to conclude. Thank you. Back to the organizers. Thank you, everyone.
So thank you, Dr. Abhishek. So moving ahead for the closing remarks, so I would like to invite Dr. Shyam Agarwal sir to give his closing remarks, sir. Thank you.
So thank you, everyone, for joining in from the first talk. So everyone, including Dr. Ashish, Dr. Abhishek, Dr. Mashmi, Dr. Aditya, Dr. Aarti, and Akhil, and all the panelists. This was a wonderful sort of display of the data, which is emerging so very rapidly for both the types of malignancies, biliary tract and HCC, and immune checkpoint inhibitors are certainly, ruling the roost here and making patients do better and better. And the long-term survivors, which were unheard of in these two subtypes of cancers, across the globe are now emerging, and we are seeing first line, second line, third line sequential therapies, and even converting patients from unresectable to resectable disease has become a reality. So thanks to all the partners here, Intas Reddy, Astra, of course, and Natco for providing us the platform. And thanks to Mr. Tarun and his team for bringing us all together for highlighting the new developments in the field of biliary tract cancer and hepatocellular carcinoma. So thank you all. Looking forward to seeing you another day on another platform. Thank you very much.
Thank you so much, Dr. Shamsa. And thank you, Tax Support, for the coordinate the session. Thank you, Avni. And thank you all the dedicate to join today's webinar. So thank you so much and good night, everyone.